Good morning, good afternoon, good evening, good night from wherever the world you're joining in. This is Dr. Pawan Kantia. I'm a pulmonary critical care doctor myself. I graduated from Maimonides Medical Center in New York, and since 2018 I relocated to India, and in my alternate hat right now I'm mostly into administration here in Yashoda group of hospitals. We are a single city based hospital based in Hyderabad, the South Indian city, which is establishing as a healthcare hub in India, and we are the leading healthcare private provider here with more than 2,400 beds currently and expanding rapidly. At the outset, I would like to thank you all doctors for taking care of these patients in a once in a lifetime COVID pandemic. Both the first wave and second wave were unimaginably busy with here physicians taking care of up to 200 patients every day, unimaginable load and day and night work. And if you do get a moment, please take a little time to for yourself before we set for the other things. And this second wave in India was pretty huge. Must have heard in the news for those people outside of the country. It was like a really demanding time here, and in addition to other things here in Yashoda, it was we established ourselves really during the second wave, and with close to more than 100 air ambulance transfers, hundreds of ECMOs, simultaneous 20 to 25 ECMOs for a prolonged period of time, besides the regular ventilators and all kind of critical care patients. We even have experience on doing lung transplants after 75 days on ECMO, and those kind of experience were new to us. And but fortunately, this second wave seems to have ebbed here, and now all the pulmonologists here, I think we can go back to the equally exciting developments in multiple other fields of intervention pulmonary. Peripheral pulmonary lesions were there from a long time, but their approach and diagnostics keep changing by the day. Looks like Dr. Vishweshwaran, our lead intervention pulmonologist from Malakpet branch, besides all our pulmonologists and intervention pulmonologists from all branches of Yashoda have taken a lot of efforts to put together a unique one-of-a-kind webinar where all the who's who of the world best in their fields, like robotic, like the new upcoming robotic bronchoscopy, navigational bronchoscopies, cryobiopsies, and general approaches, and the latest for peripheral pulmonary lesions and whatever you wanted to know. I think you'll be not disappointed after the end of this webinar. Without taking too much of your time, I would like to hand over to Dr. Vishweshwaran to take over and take it from here. Dr. Vishweshwaran, thank you very much.
Thank you, Dr. Pawan, for the introduction, and welcome participants for this International Interventional Pulmonology Virtual Meet Edition 3. This time we are focusing on peripheral pulmonary lesions, and we have eminent faculties around the world to guide us on the advancements in the management of peripheral pulmonary lesion. So I'll be starting off with the lecture on approach to the management of peripheral pulmonary nodule and current updates. So myself, Dr. Vishweshwaran, and I'm currently working as a consultant interventional pulmonology at Yashoda Hospitals in Hyderabad in India. I don't have any disclosures to make. So pulmonary nodules are defined as either rounded or irregular opacities that may be well or poorly defined with a diameter less than or equal to 3 centimeters. So once it crosses the 3 centimeters mark, that is when we call it as a mass lesion, and anything that is less than or equal to 3 centimeters becomes a pulmonary nodule. The point to be noted is 40% of these pulmonary nodules are malignant. And this is particularly so amongst the high-risk population, like patients who are aged, or patients who has got smokers, or patient who has got a genetic history of cancers. And if the nodule size is greater than 10 millimeter in diameter, then the possibility of being it a malignant is very high. Generally, nodules less than 10 millimeter in size are benign, but however, it is not always the case. And these may represent either a benign etiology like an infection or an inflammatory lesion or a vascular lesion, or it might be even congenital. So we have got a lot of guideline recommendations on the management of the peripheral pulmonary lesions. The most common one being followed is the Fleschner Society guidelines. We have a guidelines from the ACCP lung cancer guidelines. We have guidelines from British Thoracic Society, and with the lung screening protocol, the lung rads has also given guidelines on how to approach these incidentally detected pulmonary nodules when we do a low dose CT scan. So what we have to really look, and can CT help in assessing whether it is a benign or a malignant lesion? So there are few characteristics of the nodules which we have to give consideration for having a pretest probability of whether it is a malignant or a benign lesion. The most important one is the nodule size. It is the primary feature that suggests the likelihood of a malignancy. And the Fleschner's guidelines says that the estimated cancer likelihood is less than 1% for solid nodules if it is less than 6 millimeter in size, and it is between 0.5 to 2% for solid nodules measuring 6 to 8 millimeter in size, and it is 3% for nodules measuring larger than 8 millimeter in diameter. So size matters, and it is one of the most important criteria for you to have a pretest probability whether it is a malignancy or not. And in the national lung screening trial, the positive predictive value of a positive screening increases as the nodule size increases up to 3 centimeter in diameter. Apart from the initial presentation, initial nodule size, what really helps in differentiating a benign and a malignant lesion is the growth rate assessment. 2-year stability of a nodule diameter has been considered as a reliable criterion for benignity. That means if within 2 years your nodule does not show any progressive increase in size, then probably you are dealing with a benign etiology. But however, this may not be applicable to a ground glass or a part solid nodules, because such nodules can still represent a slow growing tumor like a lipidic form of an adenocarcinoma. And subsolid nodules require longer duration of the follow-up because they double in a volume within 3 to 5 years. So probably even after 2 years, if you have a part solid or a subsolid nodule which doesn't increase in size, it does not mean that you are dealing with a benign lesion. Probably you may be dealing with a slow growing malignant lesion like in the form of a adenocarcinoma. So this is a CT which is at an initial presentation which has a very small GGO, and at 3 years of follow-up you see the GGO slightly increasing, and at 5 years you see the GGO further increasing, and at 9 years it is almost bigger in size. So this is a case of a lipidic form of a adenocarcinoma which was diagnosed after almost 9 years of follow-up. Apart from this, the most important thing we have to assess is the morphological characteristics. It can be a solid or a subsolid which has got a ground glass opacity or a part solid attenuation. And generally these subsolid nodules are benign nodules. It may be in the form of a focal organizing pneumonia, or it may be in the form of a simple pneumonia, focal fibrosis, lipoid pneumonia, or a pulmonary hemorrhage. But however, if these part solid nodules remain to persist, as we have seen in the previous case, it might still suggest a malignant process. There are few other characteristics like the presence of the calcification, which can give an idea whether we are dealing with a benign or a malignant lesion. If you have got a diffuse, laminated, central, and popcorn-like calcification, then probably you are dealing with a granuloma. This is more so for areas which have got a high endemicity for tuberculosis or fungal infections like histoplasmosis and coccidomycosis. If you have got an eccentric calcification, then probably you're dealing with a malignant nodule. And generally, a thin reconstruction CT is required for optimal evaluation for the presence of calcification within the nodule in order to avoid the motion artifact, which may mimic as some sort of a calcification. There are few characteristics which are very specific for a nodule to be malignant. If your nodule is having a spiculated margins, as in this case, which suggests the presence of fibrosis or a direct spread of a carcinoma into the adjacent parenchyma or a lymphangitic tumor spread, then probably you are dealing with a case of a malignant nodule. In addition to this, as you can see from the picture B, there is a presence of a bubble lucency. If you have got a bubble lucency within a part solid or a GGO nodule, then probably you are dealing with a adenocarcinoma. In addition to this, the presence of an air bronchogram within a nodule may suggest a malignant process in the form of a lung adenocarcinoma or a bronchus-associated lymphoid tissue lymphoma. So when you have any of these features in a CT scan, then your pretest probability for malignancy should be high, and such nodules should be biopsied as and when required. In addition to this, when you are doing a contrast CT, you can look for the presence of an enhancement characteristics. If the net enhancement post-contrast is greater than 15 Hounsfield units, then the sensitivity and the specificity for diagnosing malignancy ranges between 98% and the specificity ranges somewhere around 58%. And the positive predictive value is 68% and the negative predictive value is 96%. So the negative predictive value and the sensitivity of the test is very high, and that may help us when we are dealing with such cases where attempting a biopsy might be risky for the patient. And in case if the enhancement characteristic is more than 30 Hounsfield units, this provides a sensitivity of 99% and a specificity of 54% for detecting a malignancy. In addition to this, virtual non-contrast image using a dual energy CT technology has also been found to show better performance in nodule characterization, and it is associated with a lower radiation exposure. So with the use of the PET being easily accessible these days, does the PET CT really have a role in the assessment of these nodules? These are more sensitive and accurate for malignant nodule characterization. But there is something which is referred to as a morphological metabolic dissociation sign. So this is generally seen in solitary nodular invasive mucinous adenocarcinoma of the lung, where the nodule takes a scanty FDG uptake because of the slow growing nature of the tumor. But however, it turns out to be a malignant lesion. So if you have this morphological metabolic dissociation sign, then probably you are dealing with some sort of a adenocarcinoma. And it is not necessary for characterization and staging of pure ground glass nodular lung adenocarcinoma. As we have seen before, these lung adenocarcinomas progresses very slowly, and therefore your PET may not give an actual representation of what the process going on within the nodule. In addition to this, there are few areas where MRI can really help, but in most of the cases, our CT does best for a pulmonologist. And these are used in the diagnosis of the benign lesions to avoid the need for histopathological proof, like you don't want to subject a patient for a percutaneous biopsy or a surgery in high-risk patients whose lung functions are limited, like in an advanced COPD. An MRI can give you idea about whether you are dealing with a silicotic nodule or a tuberculoma or a hamartoma. And lung cancer, pulmonary metastasis, and low-grade malignancies such as carcinoids and lymphomas have a characteristic MRI finding in a diffusion MRI, which shows a low or an intermediate signal intensity on T1 weighted imaging and slightly high intensity on a T2 weighted imaging. But for all practical purposes, your CT is the one that is recommended by all the guidelines for initially identifying as well as for following up these pulmonary nodules. So once you diagnose the pulmonary nodules, what are all the treatment armatorium we have to diagnose whether we are dealing with a benign or a malignant lesion? So one of the most commonly used and easily accessible is the transthoracic needle aspiration, needle biopsy or an aspiration. So it has got a sensitivity of as high as 90% and the specificity is 95%. But however, in one study, they found out that even despite CT guided biopsy, they had a non-diagnostic results of as high as 27.6%. And this is fairly common if you are not targeting the representative portion which represents the malignancy within the nodule. If a nodule is having some areas of necrosis, probably if you are hitting the necrosis, then probably you can have a negative report. And it is associated with a pneumothorax in 8 to 30% of the cases. This is what really differs us from going for a transthoracic needle biopsy, especially when you're dealing with high-risk cases like an emphysematous lung. And it is also associated with a pulmonary hemorrhage of 4 to 27%. So if you are not going for a transthoracic needle biopsy, so what other modalities we have? We have the bronchoscopic techniques, which in the further lectures, you will be hearing to the experts speaking on what and how and when you really have to use it. So the radial EBUS gives a diagnostic yield of 70.3% and a sensitivity of 73%. The complication rate is 2.8%. Your electromagnetic navigation bronchoscopy in meta-analysis has been found to have a diagnostic yield of 70%. And right now we are heading to the revolution of a robotic bronchoscopy, which is almost replacing all these pre-existing modalities. And in the further lectures, you will be hearing from the experts on how this robotic bronchoscopy is helping us in achieving even biopsies from a ground glass nodule and increasing the yield of your bronchoscopic techniques. And the last one, what we have to always remember is surgical resection is still an option. Wedge resection is the preferred diagnostic approach for intermediate nodules with a high pretest probability. And for nodules that are located deep, which are smaller in size, that is less than 1 centimeter, or which has got a subsolid attenuation, several other localization techniques of these nodules can be done with the help of a bronchoscope like a hook wire or a microcoil, or a radio guidance or a methylene blue. And this helps the surgeon in localizing this particular nodule while taking up for resection. And similar 5-year overall survival and recurrence-free survivals are seen irrespective of the extent of surgery. That is, if you do a bed resection or a segmentectomy or a lobectomy, still your 5-year overall survival and recurrence-free survival remains the same for GGOs, and multiple studies are still underway. So putting in a nutshell, these are the guidelines which we have. We have a flesh nurse guidelines, we have an ACCP guidelines, and we have a BTS guidelines. And the most important characteristic thing that all these guidelines take into consideration is the size of the nodule. But however, each of these guidelines differ in their approach to the size of the nodule. For example, the flesh nurse gives a recommendation for less than 6 millimeter, 6 to 8 millimeter, and greater than 8 millimeter, whereas the ACCP goes further smaller diameters like less than 4 millimeters and 5 to 6 millimeters, 6 to 8 millimeters, and greater than 8 millimeters, and which is similar to that of your BTS, except that it starts with 5 millimeter nodule. In addition to this, the characterization of the nodule is very important, whether you're dealing with a solid nodule or you're dealing with a ground glass opacities or you're dealing with a part solid nodule. That makes a difference in your approach to your follow-up with a repeat CT scans. And there are few prediction models for the risk stratification of the pulmonary nodule, whether there is a very high pretest probability of malignancy or not. They take into multiple clinical variables like age, smoking, pack years, and even history of extrathoracic malignancies, weight loss, severity of the symptoms. And they also take into consideration the radiological characteristics like lung nodule, the nodule size, the nodule edge, the location, and the growth rate. And based upon this permutation and combination, you have got you do the logistic analysis, and then finally you can, to certain extent, say whether you are dealing with a high pretest probability of a malignancy or not. This is especially useful when you have limited resources where you cannot subject all the patients to biopsy. You can use these stratification models to triage your resources in dealing with patients. Thank you everyone for the patient listening. So now we'll move on to the lectures by our expert faculties, and in the end we will be having a panel discussion. Thank you. So move on to the next topic. We have navigation bronchoscopic techniques in peripheral pulmonary lesion, and to present this topic we have Dr. Michael Pritchard, who doesn't require any introduction. He is the director of the chest center of the Carolinas at the First Health, and he is the past president of the SAB USA. Sir, please, you can share your presentation and go ahead with the talk. Thank you.
Thank you for the introduction. I appreciate being invited to speak to your conference today. I'm going to be talking today about various navigation bronchoscopy techniques for peripheral pulmonary lesions, and we'll do this as a case-based approach. So we'll look at different videos of different technologies that are out there for this. Here are my disclosures for your review. So we'll look at electromagnetic navigation. It's obviously the most widely used and the most widely known. And then now we have some adjuncts to electromagnetic navigation bronchoscopy with various tomosynthesis algorithms. We'll talk about that, as well as augmented fluoroscopy guided platforms like lung vision, also Colombian Ct and robotic bronchoscopy. And I know you have individual lectures coming up on those as well. So it'll be interesting to get different perspectives and see various cases. We know that there's some limitations for electromagnetic navigation bronchoscopy. Specifically, there's dynamic changes in the target from the time of imaging, your pre-procedural CT scan, to when you actually have the procedure itself. We know that you can have suboptimal scans. There's a lot of ferrometallic interference. There can be poor registration technique. Ground glass lesions can be difficult to see. You have to deal with respiratory motion and atelectasis, as well as positional changes with instrumentation. So Superdimension, made by Medtronic, has come out with tomosynthesis-based fluoroscopic navigation, or what they call FluoroNav. And basically, you're doing a sweep with your C-arm to create a tomosynthesis image so that you can see the target and then adjust. So what that does is, again, it enhances the visibility of the target, and we've been pleasantly surprised that we can see even lesions that are semi-solid with this. And it creates a tight focus on the area of interest and provides a more precise registration to overcome CT to body divergence, which we know exists in just about every case. Once the nodule location is confirmed, then it talks with the navigation system. It updates the target, in this case, the green ball, to a new position, and that's called local registration. So what we do is we perform an initial registration and we navigate out to the target. We just need to be within 2 to 3 centimeters within the target. And then we do this local registration technique where we spin the C-arm while shooting fluoroscopy from 25 degrees LAO to 25 degrees RAO. And that captures images. And then there's a software algorithm that processes that. And the physician will interpret those images. They'll mark the target, and then we update the position. I'll show you a little video of what that looks like. In this case, this is a very small semi-solid lesion in the right upper lobe. And you can see this in multiple planes. It's not very solid. So this was really a true test. So this was our initial navigation. We're pretty close to being right on target. We line up the center of this, and this is our tomosynthesis scan where we spin the C-arm. And then we look at the software algorithm, and then we determine where the lesion is. And what we can see is we're actually past the lesion. As we scroll through this, you can see our target as well as the tip of our tool, and we've gone past the lesion. So we're going to tell the computer where we see the lesion, and it's going to update the position. And then we have to pull the catheter back, adjust our position. You can see in the top right corner, it says local registration is on. So that's a new position. Then we confirmed this with cone beam. We did a study confirming this, and there's the accuracy right there. So that was very impressive. We published this data specifically with comparison with cone beam CT scan, looking at the accuracy. And we found that before the correction, we only had about a 68% overlap with the true lesion. But after correction, we had a 95% overlap with the true lesion. And so, it's hypothesized, of course, that this will increase your diagnostic yield. There was a retrospective study done by the folks at Vanderbilt that looked at their data before they used FluoroNav and then after they used FluoroNav. And what they saw was that they had a 25% increase in their diagnostic yield compared to standard E&B. So 55% with standard E&B and 79% when using fluoroscopic navigation. So that's exciting results. So augmented fluoroscopy is when we superimpose images right over top of the fluoro. And you can navigate with this and combine this with tomosynthesis. And this is a product called Lung Vision made by a company called Body Vision. This uses any existing C-arm. You don't have to have a specific C-arm like you do with FluoroNav. With FluoroNav, you have to have a GE 98 or 9900 with a 12-inch imager. With this, it's taking that raw fluoroscopic data, putting it into a computer, and then superimposing it right on top of your screen. And we looked at this and we did a study comparing this with its accuracy compared to cone beam CT scan. On the top left image, you can see, I know it's hard to see, but you see a pink line that is the pathway, and then the yellow circle, which is the target. And then we compared that with the augmented fluoroscopy that comes with our cone beam CT scan. And we had very high accuracy between those. There was a small multi-center study, 200 patients at 6 centers in the United States, and we were looking at lesions at about 17 millimeters on average, but the smallest was 5 millimeters. And 86% we had localization success, and our overall diagnostic yield at that time was 78%. And that was an abstract by Kyle Hogarth, who's going to be one of your speakers later, and has extensive experience using this. This is a case by Dr. Gilday at Cleveland Clinic. The video will pop in and out. That's just the fluoro save feature, but we're putting out a catheter and we're using the pink line as a guide to advance that towards the target. And that's what augmented fluoroscopy in this case is. And then you can localize that and you can verify it with what's called CABT. So once we're in position, we're going to do this very similar tomosynthesis spin, just like you saw with FluoroNav. But because of the specific catheter that we use, so there's the CABT spin on the right, you can actually see the lesion. There's the preoperative CT scan on the left. And then because the catheter we use has markers and it's detected by the system, we can spin that around in 3 dimensions and really see exactly where we're at. So we published this study, 51 patients, average lesion size of 18 millimeters. And with 12-month follow-up, we have an 88.2% diagnostic yield. What we saw also was that we measured CT to body divergence during the case. The average CT to body divergence was 14.5 millimeters compared with the preoperative CT scan and the intraoperative scans. And that's a lot of divergence, particularly when you're going after very small lesions. You can see the range of divergence went up to 3 centimeters. And this is with us using our advanced anesthesia protocols to help prevent atelectasis. We still get CT to body divergence. So having these type of software algorithms to use tomosynthesis with to correct and overcome CT to body divergence is incredibly important. We did kind of a sub-study with this, and this was in the publication as well. And we wanted to compare the accuracy of the position of lung vision with cone beam CT scan, which is the ground truth. And we saw that we're within about 6 millimeters of cone beam CT scan. So that's certainly encouraging. So what about cone beam CT scan? I view this kind of as the gold standard in terms of knowing where you're at in the lungs. There's a variety of systems that are out there. There's now mobile systems made by Siemens called the CO Spin. And what we do with this is we really want to use the augmented fluoroscopy and be able to check in multiple planes so that we know exactly where we're at. So this is what the lesion looks like on standard fluoro. Doesn't look like anything. Then with augmented fluoro, we can look at different angles. This is RAO 40, and I can see that we're on target there. Then LAO 40, so we have these orthogonal angles. And that blue dot, that augmented fluoroscopy that's enabled by doing the cone beam spin, and this is specifically with the Philips system, enables us, we can even go completely lateral. So anterior there is on your left. This is a lesion right behind the sternum, and we can see that we're in good position with the augmented fluoroscopy. Here's how we navigate using this. So we can navigate in real time and adjust our catheter into the lesion with augmented fluoroscopy. And then if you want to, you can do another cone beam spin so you can see this tool in lesion. So that's, or in this case, you think that you're in the lesion, but when you spin it around, you're actually not. And so that's very important. And so the advantages of cone beam CT scan are quite clear. Here's just a quick video showing you some of these confirmation, or what we call tool and lesion confirmation, where you can do these scans and see that your tool is right in front of the lesion. Or if you're using a needle or a brush, you can see that your tool is actually in the lesion. So we published this study in 2018 looking at the use of cone beam CT with augmented fluoroscopy combined with electromagnetic navigation, as that was our navigation system at the time. We had excellent data with this, which I'll show you. And then after this, we actually moved into a period of time where we just used the steerable catheter, the edge catheter, without any navigation system. So we just used cone beam CT with augmented fluoroscopy with the edge catheter and got rid of electromagnetic navigation and also had very good success. So this was 93 consecutive lesions. We also did multiple lesions. We did bilateral lesions. The average lesion size was a very small 16 millimeters. Bronchoscopy was only present in 39% of these cases. That's definitely something that we want to dispel. The bronchoscopy is great if you have it, but if you don't have it, it does not mean that you shouldn't do the case, and it doesn't mean that you won't have success. So this was these two different definitions are based on the acquire definition or the navigate definition, depending on which study you like better, or just so you can compare apples to apples. But we had excellent diagnostic yield and accuracy with this system, and you can see the numbers there. So if you look at other studies that are out there, the Navigate study, average lesion size was 20 millimeters with a yield of 73%. There was a thin scope and Rebus study, which showed a yield of 49% with 3 centimeter lesions. That was a randomized study. And then our study showing a diagnostic yield of 94% with only 16 millimeters as our average lesion size. So what about robotic bronchoscopy? That's an exciting topic, and I know Dr. Hogarth is going to talk a little bit about this. He has the Monarch system, so I'm going to let him cover that, and I'm going to cover the other system that's made by Intuitive, which is called Ion. So these are just a couple of examples of what the screens look like and where we're at and how we can get this robotic catheter very far out into the periphery. It keeps a time, so you can see in the red circle at the top, this is how long it takes us to get to these lesions, not only to do registration, to do navigation, but also to do confirmation. You can see integrated right on your screen is your radioprobe view there in the bottom left. So in 3 minutes and 25 seconds, we've registered, navigated, and confirmed our location. And because of the shape sensing technology, so this robot, the ION robot, does not use electromagnetic navigation. The robot with Monarch uses electromagnetic navigation as well as some optical cues as well. But this system is able to tell us, look at the measurements there in the bottom. You see we're 9 millimeters from the front edge of the tumor, 21 millimeters from the far edge of the tumor, and then 27 millimeters from the pleura. So we always know exactly where we are with the pleura, and that's a plus. So here again, 3 minutes and 20 seconds, we're able to get to very difficult lesions and confirm them on radial probe. This is one of my favorite cases. This was actually a small cell carcinoma. So a very small lesion, very sharp angle, and we're able to get our tools around there and get a diagnosis in under 6 minutes. Here's a video of what that looks like so that you can see. This is a 55-year-old male. He had 2 separate left upper lobe lesions, has a history of melanoma, and also smoking history. So I had 2 different lesions in the left upper lobe that we were concerned about. This is what docking the robot looks like. The robot is actually the scope holder. There's a magnetic adapter that goes on the end of the endotracheal tube and just attaches, and that's how it happens. This is what the robotic navigation looks like. That's just the registration process. We finish that up, takes about 1 minute. And then we follow the path to our lesion. This is what driving it looks like. You have just 2 controls there, one for in and out and one for direction. And we just follow the guide, and we have a 3D map on the top of the screen as we drive through this. With robotic systems, you don't have tactile feedback. So if you see in the top right, there's something called drive forces there. If we lose our vision, which you'll invariably do with any robotic system as you start driving through bubbles and things like that, you can continue to drive forward and you see whether you're running into any obstruction or anything like that. So the drive forces will turn yellow if you're running into any issues, but you're not running into any issues there. We drive out, we can see the lesion, we have vision all the way out to the lesion and to the pleura itself. We put the radio probe in and we can see that we're in a good location. So we go ahead and do the biopsy. This is a needle, this is a proprietary needle, and it locks into the system like an EBUS needle, and you can set the depth. So you remember I told you that you can tell how far away the pleura is. Well, now you can set a needle and your needle will never go any further. You can also put forceps through this or any other tool that you'd like. So then we're navigating to the second lesion. And we had on-site pathology. The pathologist didn't feel like this lesion was malignant. So we went ahead and moved to the second lesion, and we're driving out there deep into the periphery of the lung. And then when we get there, we'll put out our radio probe, and we can see that we're on target there. Put out our radio probe, we get a little eccentric view because it's bouncing off the side of the lesion. But we know if we just aim at the target, the advantage of the robotic scope is that it will not move. It doesn't deflect. So if we aim it at the target, it will go into the target. Our pathologist looks at this and finds necrotic granulomas with AFB in these cases. This is another example of a bilateral case that we did the other day. Here you can see the time. So in 1 minute and 53 seconds, we've registered, we've navigated out to the lesion, we've got an eccentric view. We'll go ahead and start doing some biopsies. After about 7.5 minutes, I put the radio probe back in. Now we've got a concentric view. And then after 17 minutes, we're already at the second lesion. We've biopsied that, we've confirmed our location. This is just a handful of lesions that we very commonly biopsy. All these were diagnostic with our combination of these 2 things. This is just an interesting video that I'll show you of driving the robot through incredibly emphysematous lungs. You can see this patient has horrible bullous emphysema and there's a pleural-based lesion there. And so nobody wanted to do a CT-guided needle biopsy or anything like that. This is real time. This isn't sped up. You can drive the robotic scope fairly quickly. It's very responsive. It's very small. So the catheter on this scope is only 3.5 millimeters. So it's incredibly small and it can get to very small spaces. So we get to the entrance of this kind of bulla and we're actually able to push forward and drive into this. So what you're just seeing here is inside this emphysematous bulla, There's some residual vascular structures there and tendrils of vascular structures, but there's no discernible lung tissue at all. So we're going to navigate our way through these to this pleural-based lesion, and you can start to see the lesion, this white plaque on the back wall. It's very important to have those measurements there in front of me. I know exactly how far I am away from the target, and importantly, how far I am away from the pleura, so that when I use my needle, I can set the depth and I know exactly how deep my needle is going to go. So we drive up to this lesion, we have vision the entire time, and we're seeing things that we've never been able to see before in the lung. So it's quite impressive. You can see that the lesion correlates perfectly with the virtual lesion in this case. We put our radial probe out, we get a little bit of an eccentric view, it's bouncing off the side. But again, even though it's not supported by any lung tissue, that catheter is holding its position. It's not falling down, it's not moving. Even when we do needle biopsies, see it push back a little bit, but it's holding its position directly at that target. And we get a diagnosis without any complications. So we've gone after lesions like this, way up in the apex. You can see how far this robotic catheter can really stretch. Here you can use augmented fluoroscopy and get all the way out to the target. You can do a cone beam CT scan if you need to, and you also have vision all the way out there. So you can see these mucosal irregularities all the way out to the level of the pleura. So we've got some data that's just been presented at ATS with ION specifically. This is 76 consecutive cases. This was without cone beam CT scan at all. Average lesion size of only 17 millimeters and a diagnostic yield of 62%, 0% pneumothorax. Because we always know where the pleura is, and because you have that needle that allows you to know the depth, I think it makes for a much safer procedure. So we're seeing 0% pneumothorax in a lot of these cases. And then when we combine the robot with cone beam CT scan, you can do some pretty amazing things. So here with augmented fluoroscopy, it looks like we're right on the lesion. But again, I said check multiple views. Here we can actually see we're just posterior to the lesion. I can make a slight adjustment on my robotic system, and I can make a small adjustment right into the target. We can do a cone beam CT scan, and we can see that I'm right in the middle of this very small and peripheral lesion. And we also want to confirm that in all three planes. So this is our data. This was just accepted as an abstract for CHEST. We'll be presenting this in an oral presentation. 92% diagnostic yield and 232 consecutive lesions. We did use cone beam CT scan sometimes. Average lesion size of only 14.5 millimeters. And our yield for lesions 10 millimeters or less is nearly 90%. And that's out of 58 lesions. You can see our pneumothorax rate is 1%, and we had no significant bleeding. Here's just some examples of what that looks like. Tool and lesion confirmation with the intuitive robot combined with cone beam CT scan. This is just a matrix of the data that's out there existing right now between several of the systems that we've talked about today. Everything to the left of the red dotted line is an average lesion size of less than 2 centimeters, which is what we're going for. We want to have high accuracy, so high on the y-axis, and we want to be further to the left on the x-axis. So you can see that some of the robotic technologies out there is really getting us high accuracy and less than 2 centimeters. So here's some of the new studies that, again, are coming out. And that's it. So we'll end the talk there. Please feel free to email me if you have any questions. Enjoy the rest of the presentations in your conference. You have some great speakers coming up today. And thanks again for having me.
Thank you, Dr. Michael Pritchett, for an excellent presentation on the navigational bronchoscopic techniques in PPL. So to have the talk on the cone beam CT in the management of PPL, we have Dr. Gustavo Cambo-Nacheli. He is at Spectrum Health, Universidad Nacional de Rosario Grand Rapids in Michigan in USA, and he will be speaking on cone beam CT in peripheral pulmonary lesion. Sir, you can share your presentation.
Thank you for the introduction, and I appreciate the International Interventional Pulmonology Committee setting up the third edition. My name is Gustavo Cambo-Nacheli. I am an interventional pulmonologist in Grand Rapids, Michigan at Spectrum Health. I specialize in peripheral lung, nodule, and peripheral navigation, and I leverage the use of cone beam CT technologies, both of the platforms available. And I will, for the next probably 20 to 25 minutes, I will be discussing a few key aspects of how I do the work that I do in order to get to those tricky nodules. Why do we build a cone beam CT program? Why does it impact, and how does it impact a pulmonology program? How do we intertwine cone beam CT with robotic platforms, and what are future uses? The reason why we decided to invest resources in a cone beam CT scanner essentially was part of a larger plan for the interventional pulmonology at Spectrum Health. Part of what we decided to grow was the axis in which we wanted to become from a reactive nature bronchoscopy program to a world-class. And one of the areas that we take pride on is the leveraging of different technologies, robotic technologies, cone beam CT, and the like. The problem that we're having in the United States is that the 5-year survival rates are dismal for advanced stages. Therefore, in earlier stages, once we can get to the nodule as it is small, the likelihood of survival at 5 years is exponentially higher. And as we very well know, we have large nodules, we have small nodules, and we have masses. That's 3 centimeter difference between a nodule and a mass. And we are anticipating that approximately in 4 to 5 years from now, we will flip the ratio and we will be diagnosing earlier stages as the areas of concern are at the nodule stage and not at a mass with nodal disease. Cone beam CT, we will get into the technology overview very briefly, but what we want to do is we want to leverage the eyes on the nodule, eyes on the target with precision and accuracy. Some tools that we use have precision and not accurate, and some are accurate but not precise. When we talk about small targets, cone beam CT technology lets us see exactly where the tool is, and hopefully we can develop the experience across the country and across the world in order to be precise and accurate in order to reach these small nodules. And what we want to do is we want to say, we have the technology, we have the tool, we have the cone beam CT scanner, we have a multiplanar 3D reconstruction fluoroscopy arms. How does it help us, and how does it help us confirm that the tool in the lesion relationship will translate into hopefully a higher diagnostic yield? Therefore, once we use cone beam CT technology, multiple authors in multiple centers across the country have demonstrated that it increases the likelihood of hitting the target in the middle if you're off center, or hitting off center if you were to perform a biopsy with a miss on the tip of the tool. And why do we decide? Because we have seen and we've learned in all of these years that the electromagnetic navigation, legacy technology, and older versions of peripheral lung navigation, unfortunately have a poor diagnostic yield of approximately between 70 and 75%. And that's not enough to be able to diagnose only 3 and 4. Therefore, we are exploring ways to bridge that gap that we so desperately need in diagnostic yield for diagnosing our patient earlier. When we discuss robotics, we discuss the ability of a platform to reach the target and leverage stability, control, and vision, and able to get in the space. So robots get us there, but the distance between the tip of the robot and the nodule usually is roughly 1 centimeter. You don't want to be on the nodule. Otherwise, you're going to overshoot with your instrument. So the promise of cone beam CT technology is that the robot gets you there, but cone beam will get confirmation real time of tool and lesion. Therefore, we can leverage also that for safety, as we were able to confirm that the tool is away from pulmonary arteries, other vessels, pleura, and we will be able to exactly know where the tool is in each of these cases. Where is the forceps, where is the needle, or any other instruments as brushes or the like. So to me, when I discuss the likelihood of patients being able to be diagnosed, I separate the procedure in 4 different stages. Diagnostic yield is essentially the sum of all of these things. 1, to reach; 2, to confirm the tool is in lesion; 3, obtain enough tissue by sampling; and 4 is leverage best technological advancements on laboratory techniques in order to be able to tell what's going on with the tissue that we provide the pathology. So this is a sum of all of these things will translate into a diagnostic yield. and diagnostic yield has to do with the true positives over all the cases. In this country, nearly 500,000 people die a year, and 130,000 roughly are due to lung cancer, more than many other cancers combined. Therefore, we have a significant problem, as we have a lot of deaths, almost one-to-one diagnosis to death on a yearly basis, and we have not found ways to diagnose this early. Lung cancer screening has helped, but not necessarily fixed the problem. So with lung cancer in the country, we needed change. And the change comes in the way of innovation with technology and also education for physicians, as they are integral to be able to be able to diagnose patients with small nodules. So when we need to reimagine the way that we do things. We need to relearn the way that we do things. And we need to think about, how about if we can flip the ratio from late stages to earlier stages and not having to repeat procedures. Therefore, from presentation to diagnosis to treatment, we will have a shortened period of time as not to allow a tumor to advance to the next stage. Therefore, provide more nodules without nodal disease to our surgeons in order for them to perform curative intent surgery, or in the not so distant future, be able to bronchoscopically ablate these nodules, or be able to instill chemotherapeutic agents in order to achieve local control. And this is where we are taking lead in the fight against lung cancer. And what we do is we leverage two different technologies, robotic bronchoscopy and cone beam. Cone beam CT has been at the least controversial. There's some believers, there's some that are not necessarily convinced with the data. But I invite you to look online really quick, a search about work that has been done all across the world. We have a couple of leaders, as Dr. Casal, Dr. Pritchett, and others in the country that have been working with different platforms, whether it be Philips or Siemens. And there's abundant publications that, at the very least, increase the diagnostic yield by 5 to 10% points. Therefore, without doing a journal club and dissecting each paper, I can, with confidence, based on the deep knowledge that I have about the technology and the literature that has been published, I believe that for those that have a CAT scanner available, if they have a way to retrofit their bronchoscopy platforms and make cone beam and robotics work, that's where the magic can happen, and you can get to very small targets. Cone beam CT, briefly, is essentially the difference on the way that the rays are impacting on the patient. Whether you have a fan beam or a cone beam, that's essentially the name of the technique in which the rays are going to be impacting the target and be able to visualize. Whether it's an O-ring, whether it's true cone beam CT with a C-arm with reconstruct, or spin, all of these are different floor-mounted, ceiling-mounted, mobile. Any CAT scan really can help you develop some sort of CT guidance, if you will, for directing the tools where they need to be. In the case of spin, which is primarily the one that I use, I also use Philips. It's a very small platform in which it has a C-arm, which is mobile, and it has a tower that displays what we want to see. If you further dissect, you can position yourself at the head of the bed, you bring the C-arm on the side, and you can see that the footprint for the monitor trolley and the C-arm chassis are very modest, are essentially the same size as a fluoro arm. The anatomy of the C-spin, which is the system that I use, which is a true cone beam, it has essentially collimators and detector grids and the space between these two parts in the patient, the gantry, and has a digital panel for you to be able to mobilize the C-arm and the console as well. And the trolley essentially has a printer, a drive, and two independent displays in which you will be able to see the images that you're capturing. When we work with robotic bronchoscopy, we slightly adjust the robot at an angle in order to allow for the C-arm to come. The next slide is essentially a video of a cone beam CT case that we perform with Philips in the operating room, in which you can see in the back a robot that is already introducing the patient. It's already navigated to the lesion. I have the radial probe with an eccentric signal, and I do a very, very quick spin with the Philips arm, and then we wait for a few seconds, and we have a 3D reconstruction in order to know where we are. With a spin from Siemens, it's essentially the same. We can rotate fully, and we will be able to reassemble images in the three planes, axial, coronal, and sagittal. You can see the three planes in the left, and you can see the axle on the right, and you can see very clearly. This is another case that we did with spin in my bronchoscopy suite. The patient has been navigated, we already robotically navigated, and we have 3 different settings. In the setting for the spin can take 30 seconds, or if you need more power, we need a 60-second spin with a ventilatory hold. For the most part, the 30-second ventilatory hold with SIO spin, we can monitor everything, and that's all it is. As you can see, with a spin, we don't have a proximity guard. Therefore, it's very forgiving for various patient sizes and various setups. And when we work with Philips, we have integrated this seamlessly. There's a theoretical concern of interference between the robot and cone beam. All we do is we do a first spin with cone beamer in order to make sure that the nodule is stable or improved. If it's shrunk, we abort the case. And if it's there or worsened, then we move the arm out, we bring the robot, we navigate, and once we reach the target and we have some sort of ultrasound confirmation, we move forward with the needle or forceps, and we spin a second time. If the tool is not where we intended to be, we adjust and respin. Usually these cases take anywhere between 2 and 5 spins, depending on the complexity of the case. You can see the Monarch robotic platform, in which is perfectly aligned with the target, and we can see with Dr. Egan, my colleague, exactly where we are in cone beam CT. In this case, you have an eccentric lesion. We are within 70 millimeters, and I was able to, again, spin it one more time and confirm that the tool is in the lesion. This is a display for Philips. We have segmentation and Embo suites and all of this software that is incorporated in Philips, and we can segment the nodule, and we will be able to follow the instruments and make sure that we are hopefully in the center of the lesion. And if not, we will provide a sample to the Cyto Technologies that is in our room. And if they have diagnostic material, we get anywhere between 4 and 8 passes, and then we move on. These are videos essentially how does the instrument look on Philips cone beam CT with the 3 images. That's the robot. We have the needle that may have traveled a little too lateral, but you can see that it's going in the lesion. And this is one of my first cases, but you can see very well that the tip of the needle is in the middle of the target. In future state, we will be able to leverage this cone beam CT technology in order to ablate the nodule. Whenever we talk about segmentation, essentially we have the nodule that is delineated and highlighted, and therefore we can start rotating and seeing where, in this case, my forceps was slightly on the side, but I can see very well that it's in contact with the nodule. Therefore, it gives us reassurances that we are on the right path. Again, we spin a second time or a third time until we are pleased with the location of the tool. Another example how we segment one of the nodule masses, and with augmented fluoroscopy, we can tell that we are where we need to be. Some cases for you to see also different technology that is not Philips, if Siemens, you can see very well that you can have a very small circumscribed, this was a carcinoid, and we can have a lot of clarity. Cone beam CT is particularly important for very apical lesions in which there's no airway, and areas that we may need to cross country a few centimeters. The robots and the ultra thin scopes do not compensate for the trajectory. So a forceps can go in one direction, the radial probe can go in a different airway, the brush may go in the path of least resistance, and the needle transects something. Again, for as much as this is a little large, this is very apical, and there's no necessarily airways going into this thing. Another of my initial cases that I performed with cone beam CT, almost pleural based, but this is adenocarcinoma in which there was no airway, and we were able to get the tool in the lesion and confirm. Again, ground gas opacities, you don't see this in fluoroscopy, but you do see them in cone beam CT. Very peripheral nodules are PET positives. These are not a challenge for the combination of robotics and cone beam CT. So the take-home message is the robots or the bronchoscopes or whatever you use will get you very close, but it won't tell you if the tool is in the lesion. So with the leverage of cone beam CT technology and the 3D reconstruction with the 3 planes, you can have reassurances that you are where you need to be. And if the cytotechnology is not calling it, you can just keep on biopsying. It's a matter of volume. And I would say that roughly half of my cases, the cytotechnology in the room doesn't call for cancer or diagnostic material, but I know that I will provide the pathologists with enough tissue for them to do cell blocks and continue providing me with the answers that I need. Other images with the forceps and the needles inside of the lesions. And again, we have a multiplanar reconstruction, and we can very easily get there. I ran out of airway in the left upper lobe lesion. It's rather high there. And I had to throw the instrument as far as I could. So in this case, the robot wasn't letting me go. There was a carina that was impossible for me to make. So I knew that I was in the lesion, a little bit off center, but I knew I was there. Therefore, you take a bunch of biopsies. And at the end of the day, since they were not calling it, I had to do and perform advanced techniques and work my way into that apical segment and go right next to it. How good are these specimens that are obtained with robotics with the guidance of COMBIM? They're really good. For the most part, you can see non-small cells, you can see granulomas, you can see pretty much anything that you need in order to know that you are in the space that you need to be. So where is this taking us? Well, we know that not only COMBIM is helpful for the diagnosis of nodules and masses, peripheral lesions, but also it has helped us greatly in the assistance of the surgeons to resect nodules that are difficult to find with anatomical landmarks or ground glass that the surgeon cannot feel palpate. This is a case that we did in the OR, pre-resection. We brought the Colombian Ct scanner and a protocol that we developed and published within my service. We have a protocol that we instill methylene blue and indocyanide green for the surgeon to use the Firefly and do the fluorescence in the case once there's the drop lung by whenever you induce a pneumo. And once we spin the CAT scanner, we know exactly where we are. In this case, I was directly aimed at it, but the needle went maybe by 5-6 millimeters posterior. So even though this was not a diagnostic test, it was a pre-surgical, I was able to tell the surgeon that whenever he drops the lung, the dye, it was going to be probably 5 millimeters posterior to where the area is. So this was a proof of concept. We published the first 17 cases in which all of them contained the specimen in the contain the nodule in the specimen. And to this day, we have done roughly 75 cases, 100% accuracy for inking. 100% of the nodules are contained in the specimen that was sent for evaluation. You can see how far robotics get. We got all the way to the pleura. We'll retract the robotic bronchoscopy by 1 centimeter. We instill the methylene blue and the indocyanide green. Simple procedure, takes 5 minutes, in and out. Colombian Ct scanning helps you know exactly where you are. Most of the cases we do with fluoroscopy, but if there's a challenging case, Colombian Ct always comes to the rescue. That's one of the benefits of having a mobile system as opposed to either a ceiling or a floor mounted. You cannot take your bronchoscopy suite to the OR. This is the way that it looks intraoperatively. You can see methylene blue, you can see indocyanide green, and the specimen is able to be sent, and the pathologist confirms where it is. Again, accuracy and precision is the name of the game whenever you start using COMBIMers. So last and not least, where is this taking us? We as pulmonologists and interventional pulmonologists, we envision the day in which a patient shows up in our hospitals with a nodule, and we can diagnose, stage, and treat in one setting, and the patient goes home shortly after. So we are working as a community in order to develop a fourth treatment modality, which is endobronchial or intratumoral treatments. And how does this happen? Well, we can inject agents, or we can do ablation. The next few slides are going to be essentially courtesy of Dr. Pritchett, in which there was some ablation with some areas that were able to be treated. And Dr. Pritchett is leading the way in the country when it comes down to ablation. And we're very grateful for that, in which you have a small nodule and you ablate, and with the time it leaves a scar, and following radiologically, and hopefully no complications and no recurrences. Again, Dr. Pritchett, you can see with his Philips COMBIM scanning that when the catheter is slightly off center, you could potentially do different ablation zones, and you encompass the nodule in that area. Again, very useful technologies in order to proceed with ablation trials. Other spaces in which cone beam CT scanning can be useful, gastroenterology has been very interested in the use of this, especially since they use contrast. They can see biliary trees and they can do a lot of really cool things that have not been studied yet, but that's a future direction. Urology as well, leveraging robotics for lithotripsy and urologic procedures. Cone beam CT can give the precision that they need. Pediatrics, we can use robotics and cone beam in order to remove foreign objects, especially in teenagers. And the surgeons have been very grateful that we can bring the cone beam CT scanner to the room and be precise and accurate. And GYN with procedures that they use. Again, these are applications that both robotic and cone beam CT can be extremely useful. Last but not least, we have heavily relied on robotic technology and cone beam CT platforms in order to increase the value of a program. And the reason why I bring enough value as a topic of discussion and consideration, the concept of value encompasses essentially the quality and the outcomes and the patient experience over the cost, whether it's direct or indirect. In this country, it's very, very important to be mindful of the outcomes and the quality and the patient experience, and very mindful of the cost of procedures. Therefore, if you can diagnose somebody, stage, and not have to repeat the procedure, and be able to refer to a surgeon early on, likely downstream, there's going to be significant cost saving for the federal and the private insurances, and the patient will be very grateful that we were able to leverage every technological advancement available to us in order to help them live longer and better. So to us, cone beam CT transformed or elevated the scope of practice within my interventional pulmonology and bronchoscopy division to one that has better quality and better outcomes. I appreciate the invitation of the organizing committee. Very grateful that I'm given this opportunity to talk about what my passion is, which is a diagnosis of lung cancer in the earlier stages, leveraging robotics and cone beam CT. I'm a firm believer that we should always keep our eyes open, and that's the difference between a dreamer and a visionary. I invite you to research in your local hospital what resources you may have available. With a bronchoscope and a CAT scanner and an anesthesiologist, you may be able to start doing really important work and get your initial stepping stones. A few years ago, I called a couple of my colleagues that were experiencing cone beam CT, and it was intimidating and it was cumbersome, but it was extremely rewarding. And I firmly believe that this will be a stepping stone towards minimally invasive modalities for lung cancer treatment in the near future. I appreciate the invitation one more time. I hope that you enjoy and take something home that can be put to really good use of your patients. They will be really grateful. Thank you again, and have a great rest of the course.
Thank you, Dr. Gustavo, for excellent insights into the role of the cone beam CT in peripheral pulmonary lesion. So now we'll move to the most exciting talk of this web meet, which is the utility of the robotic bronchoscopy in the management of peripheral pulmonary lesion, which is revolutionizing the treatment options that we have, which is revolutionizing the diagnostic modalities which we have in approaching a peripheral pulmonary lesion. And to deliver this talk, we have Professor Kyle Hogarth. He is a professor of medicine at the University of Chicago in USA. Sir, please go ahead with your presentation. Thank you.
Well, thank you again for this opportunity. After a bizarre year, I obviously wish I was there presenting live. I would prefer to be in India. It's always great to visit there. I've been asked to talk about peripheral bronchoscopy with a focus on robotics. My name is Kyle Hogarth. I work at the University of Chicago and I run the bronchoscopy program there. This is my conflict of interest, which I'll leave up for a second so people can read. That is germane to everything that I've involved with. So why do we need robots in bronchoscopy? What's the purpose here? So let's go back to standard flexible bronchoscopy for single pulmonary nodules. Transbronchs, brushes, or lavages across multiple studies have low yields. If there was a bronchus sign, we in pulmonary were pretty good. And if it was a bigger lesion, we were pretty good. But this was just with you and your knowledge of the scan and a scope. So then the first generation of navigation bronchoscopies arrived. Virtual bronch, electromagnetic bronch, guide sheath, ultrasound, radial EBUS. And you'll notice across all of these, multiple studies, we got better, and so bronchoscopy in the periphery improved, but there was still limited ability to get to lesions. There were definitely certain regions of the lung we could not get to, but we did have a very low pneumothorax rate, so compared to a needle biopsy, there was obviously some superiority, but we had to be a little more selective, I think, in the patients we biopsied. We obviously knew also that the lesion's relationship to the airway mattered a great deal, that if there was a concentric lesion in the periphery, we had a better chance of making a diagnosis than the so-called eccentric lesion. And that's going to be extremely germane when we talk about robotics. So when you first look at one of the largest studies in navigation bronchoscopy, and you break it down using, this is with the Electromagnetic Navigation system. This is a great paper by Kantia and then Folk. The diagnostic yield when there was radial ultrasound, as you can see, was all over the place, but very low when it was eccentric, quite excellent when it was concentric, same when it was ultimately a bronchus sign. And so the problem is that a lot of lesions don't have bronchus signs. So I think historically, we as bronchoscopists, if we had a decent lesion that had a bronchus sign, we should definitely have been approaching it with navigation, but maybe in full faith, our yield was lower, maybe not have approached the majority of the lesions that we were going after historically. So peripheral bronchoscopy obviously evolved and changed with catheter-based technologies to then ultimately the robotic bronchoscope that I'm going to talk about, both the first in human study, the pilot multi-centered study, the initial multi-centered experience, the benefit study that was recently published, and then the ongoing target trial. So the Monarch system is, you can see from the video down here, this is the controller, and it does look very similar to an Xbox controller. This is the robotic scope inside the outer sheath, and you'll notice the high degree of maneuverability. You've got an always-on camera, 2 LED lights, the nav sensor is built in at a 2.1 working channel on this scope that is inside this sheath. You can drive each separately. The sheath will then stabilize and can actually be used to help manipulate the airways. And you've got a lot of different steering sections with very excellent articulations. And first question was always that the thought process of robotics is, could you get out further? So compared to a P190, a fairly standard small scope, you can see how far in this cadaver-based study, how far the P190 could get. Because obviously at some point you can only generate so much force. And the argument's always been, well, look, you could always pass instruments out further, and that's indeed true. But if you look at the robotic scope, what you'll notice, of course, is how much further it gets. Actually, on average, about 4 centimeters further, and typically within 2 centimeters of the pleura compared to the P190. So the REACH study at least demonstrated the one thought process of robotics, which is that you and I would be able to get out further and with vision than we've ever been able to get before. The other thing is to have real-time visualization. So I'm going to show you a video.
Yeah.
You'll hear me talking on it.
See how it slides on the airway?
See the needle?
Back up. Now put the needle out. Put the catheter forward a little bit so you can see it. There, now push the needle out.
Now watch, you'll see the needle slide.
Give it a tab so you see it go through the wall.
And yet, look, it slid down. This is why you and I used to miss.
The needle out. Bury the needle. I want to see it go through the wall. Yeah, keep going. Yep, I push it in.
There.
Okay.
So what did we see there? So this is, we're out at about an 8th generation airway, and you can actually see your needle make it through the wall. But notice on the first 2 attempts by my fellow that the needle slid down the wall. So one of the reasons that you and I used to miss in the periphery before robotics was that we couldn't guarantee that our instrumentation, especially on an eccentric lesion like this, was actually penetrating the wall and gathering tissue. Now here's another great example. The lesions behind this little tissue right here, notice all the lung parenchyma, and yet we can't get the needle to go through even though the lesion's on the other side. This is about 2 centimeters from the pleura. Now watch. You can see it go through, you can watch it penetrate, and that was actually a diagnostic sample. So this precise control, now you'll watch this. This is a US dollar. This is a needle tip. You can obviously do it with any currency. The idea behind it, of course, is being able to slowly move wherever you want to go. And that precision is also useful for when you have a radial ultrasound probe where you can touch it against various walls and actually then know what wall to be going through. Feeding the instrument through as you want, but also being able to still manipulate and change the tip of the catheter. So again, when you get an eccentric view, you know which wall that's through, so you can then watch the needle go through the wall. That's what robotics is doing for us. And then changing it to a more concentric view after you've made a hole. So I already showed that video. So how do you get there? So that you'll see a live case over here, but it's 3 different ways. It's optical pattern recognition, so similar to facial recognition software, similar to like how you open your iPhone. Also combined with electromagnetic navigation, that's the standard thing. And then also insertion data, so in other words, how far in you are. So here's a registration was 30 seconds and then 38 seconds to reach the target. The registration period you see is real quick here. And then you get the combined EM optical recognition and insertion distance so that the navigation software always knows where you are as you're driving then to the lesion. And of course, you never lose optics, so you always can see where you're at. And you've studied the CAT scan, you know the branching you need to drive through, etc. So in the end, it becomes very similar to a standard bronchoscope. And then ultimately, you can see this was a nice endobronchial lesion, so fairly straightforward, but it's more just to highlight, obviously, the simplicity. So the data, we're up against, if you will, diagnostic yield of TTNA that was higher, but EMN that had a lower, but a better complication rate. When you look at localization with rebus ratios, 95%, and pneumothorax rate of 2 to 4%, pneumothorax requiring chest tube 1.9, and significant hemorrhage of 0. So you've got an ability to get out far, see, and then get the sampling you need. So these are the various studies that have been published to date. And when you look at the benefit study, this was the first prospective multi-centered robotic bronch trial, 54 procedures. There was definitely a learning curve. 74% overall diagnostic yield, 3.7 pneumothorax rate, 13 minutes average time to rebus confirmation and localization. And then if it was a concentric lesion, really excellent. But more importantly, the eccentric lesion, which had normally been in the 40s, was now in the 70s. And the average procedure time ultimately was 51% or 51 minutes. There's a 23 millimeter nodule. When you look also at the first clinical evidence of a multi-centered trial, Dr. Chada published with Dr. Kovacs, 165 procedures, the first ever procedures, and the first, also the first generation software. It's now essentially on the 5th generation software. A high navigation success, and then nodules located in the outer third, and the diagnostic yield, as you see there, and again, excellent for eccentric as well as concentric. The ongoing target trial enrollment began, clearly interrupted some with COVID, but this is an evaluation of the biopsy accuracy with the Monarch system. Is going to be 1,200 patients. So now I'm going to go into cases for the sake of time and try to highlight. So here's the CT scan. There it is. So not something you necessarily would want a needle biopsy given its location. So this case is the first ever bronchoscopy of one of our fellows, first ever robotic. So he had never touched the robot before. So just watch. So first we're registering. We touch the main carina, then we were driving into the right main bronchus. We retract, and now we're paired and we're ready to drive. So he's driving here. He's going to go down the left main stem. A little tentative at first, but you know, it was his first time. Making nice progress. Now he's still in the sheath. You see why it's blue here. It's coming up into the superior division. It's going to go down into one of the segments, but now getting a little difficulty in getting there further. So he's going to switch to the scope. Now it's green, so he's parked the sheath. He's driving the scope. Now notice as he rotates, obviously it rotates on the virtual view. Lots of branching. And he can switch his view to now get a line guidance on a single slice CT as well as the line guidance on the virtual. Periodically, he's going to hit the wall. So he'll just back up a little bit, turn around, move forward, hit the wall again. Now notice how far out he's gotten. Look where we are. You saw where this lesion was. And yet here we are driving down the airways, and there's the lesion. Plenty of branches to have mistakenly gone down, especially if we were doing a blinded catheter. And now, I think equally important, better confirmation with exact biopsies of tools. So he takes a biopsy here on the upper, more caudal or cranial portion of the lesion, superior aspect of it. Do a needle biopsy. And then what you'll see is then we take a second biopsy in the more caudal portion, inferiorly, while the first one was being processed. So a little bit of blood, nothing major. There's suction, of course, but also if you needed to back up to clear your optics, just like you would with a regular bronchoscope, you'll drive right back. And so now we're taking a biopsy in the lower part, and then we're going to just back out. And that was the end of the case. We then staged the patient. This was a single lesion. Lymph nodes were all negative, and he had a trisegmentectomy of the left upper lobe superior division the next week. This was a squamous cell. So case example number 2, this is a guy with this lesion. Now the problem with this guy is he'd had prior lesions that had been radiated without a biopsy because he was considered to have such low lung function that nobody wanted to do a bronch or a biopsy on him in any way. So what we're going to see is we're getting out to the lesion and we're eccentric to it. And when I put a radial probe down, I can see what wall it's on, and the electromagnetic said it was through that wall. And sure enough, now again, I'm getting an eccentric view. Now, if you obviously know that radial EBUS does not have a true north, if you will. So if you believed this screen, it would tell you that the tumor was off to the left, and obviously it was not. You could see what wall we were touching. It was the one off to the right. So now what we did, and I edited the video for time, we had gone in, you'll see as we drive down, we're approaching the lesion in a more direct manner, but because it was eccentric, we drove and we passed our needle through the wall and essentially broke through the wall so that you could see lung parenchyma, so that we could turn the eccentric lesion into a concentric lesion. You can see the lesion there. That allowed us to take multiple biopsies and even see mitotic figures, obviously proving a recurrence of this gentleman's malignancy. Now this one was an 81-year-old, and this is a procedure technique that we call the inverse vats. It's not really that, but it sounds really kind of cool. So she had a right upper mass, and she presented with brain mets. And for whatever reason, the needle biopsy was non-diagnostic. So you'll see this lesion. She's got a lot of emphysema. I'm actually surprised they did not give her a pneumo. But you'll see a fairly large anterior located. So this should have been an easy needle biopsy, but it was non-diagnostic for whatever reason, but it's still fairly apical. And you'll notice she had old calcified lymph nodes. So there was some theoretical concern that it was infectious, though the brain mets kind of gave that away. And what you're going to see here, I'm going to pause it for 1 second. So we've gone now, we're right in front of where that tumor was. So you can remember how far out we were. This is the airway wall. The reason we call it the inverse vats is we put a needle through, and then we just move the robot up and down a little bit and essentially bluntly dissect away the airway. And what you're seeing in here now is lung parenchyma, and that's the actual part of the mass. So this is supposed to be a very eccentric lesion that we would be normally doing a transbronchial needle aspirate. But since I've made a hole in the airway and I can see the tumor, I'm just going to pass my forceps through and make this essentially an endobronchial biopsy. Getting a nice big piece of it. We left a fiducial marker behind, so you can see it embedded in the tumor. This ended up being small cell carcinoma, but really incredible to show what you can do with this. Now, where's things going? So right now, under development is a protocol for a flexible microwave catheter that's already FDA approved, but a protocol to show that we can try to cure both primary lung cancer as well as solitary mets. That trial will be starting, helps if I go forward. That trial will be starting in the next few months within the US. Robotically driven injection of nanoparticles, that's a trial we're already doing, us and several others, to increase the sensitivity of radiation to primary lesions. A procedure that I did last week was a robotic and guided injection of infectious viruses that transfect the tumor. And then as you treat that virus, this particular transfection was with an adenovirus that had herpes proteins. Then as you give the patient anti-herpetic drugs, you get a nice abscopal type effect, or at least an increased immunity effect. And you can see actually shrinkage of tumors throughout the body. And so for this particular person, it already had one, and there was already some shrinkage. We just injected the second time. The whole reason this was possible was the ability to get there. This lesion was in their right lower lobe, but they'd had a wedge, or sorry, a segmentectomy. It was right along the suture line. We had to tunnel about 1 centimeter through lung tissue to get to the tumor. Direct injection of chemotherapy into tumors. This is another study that will be starting soon. And then another trial that we're working on the protocol for robotically guided placement of radioactive seeds indirectly into tumors, essentially a localized brachytherapy. So I think really exciting. And one of the things that you'll notice is that none of these per se, are about the robot in the sense that this is other technologies, but it's the robotic ability to get to the periphery, have the stability, and see while you're working that is opening up the entire lung for different modalities for therapeutics for you and I. And that's where I think things are extremely exciting. So I'm going to stop and say thank you. I hope I was respectful of time. This right here, this whole thing right here is the entire University of Chicago. And in fact, it keeps going this way. We're just on the southern part of the city of Chicago. This very large building here is my medical center, as well as these and these buildings. They're all part of the hospital, but this is where the bronchoscopy lab is. My email is right there, as you see, and my cell phone, and I am on several different social medias that you can reach me on if there are questions or things I can do. Don't hesitate to contact me cell phone wise, WhatsApp, or email. And with that, I will say thank you so much. I do hope in the near future that I have the chance to return to your wonderful country. I've been lucky enough to be there twice so far, and I hope to see many, many more times. Please stay safe. I know it's obviously horrible times for all of us everywhere. And so stay safe, and good luck to you and your family. May they prosper and stay healthy.
Thank you, Dr. Kyle Hogarth, for a great insight in how the robotic bronchoscopy really helps in us approaching peripheral pulmonary lesions. And I think in near future, even most of the pulmonologists here would really love to learn such innovative techniques from you and your colleagues. And in line with this, we have the next talk, which is a very interesting talk. It is about the role of the cryolung biopsy in peripheral pulmonary lesions. This is something which is becoming really important because of the eccentric lesions which we have in the radi libus, which cannot be approached with the help of a routine forceps biopsy. To deliver this talk, we have Dr. Ct. He is currently working as a consultant pulmonologist, and he is the head division of pulmonology, Department of Medicine at Sarawak General Hospital in Kuching in Sarawak in Malaysia. And he is a pioneer, and he is one of the experts in this particular field of the use of cryo in the diagnosing peripheral pulmonary lesions. So I would request you to go ahead with your presentation, sir. Thank you.
First of all, I would like to thank the organizing committee for inviting me to share our work on radial EBUS guided transbronchial lung cryobiopsy for peripheral lung nodules. I'm the Dr. Ct from Kuching, Sarawak. So in the next 20 minutes, I'm going to talk to you about guided bronchoscopy for peripheral lung nodules, and focusing mainly on the limitations, some of the limitations of guided bronchoscopy, and subsequently talk to you about radial EBUS guided transbronchial lung cryobiopsy for peripheral lung nodules, and our rationale and how we select a case for TBLC. So I think we have talked a lot about peripheral lung nodules or solitary pulmonary nodules, and various approach to get a diagnosis. And it is very important to know that lung nodules is not just, the diagnosis of lung nodule is not just malignancy. There are various infectious, inflammatories, and conditions that can give rise to this condition. Therefore, a definite diagnosis is usually needed before definitive treatments. When it comes to sampling of the lung nodule, traditionally we use we use mainly CT-guided biopsy. However, there are limitations of CT-guided biopsy for lung nodules, small lung nodules, especially in those patients who is high risk for CT-guided biopsy, like severe emphysema, and those patients who has nodule which is very adjacent to a vital structure. Not all radiologists are confident in biopsy in these cases, and therefore there should be some alternative. Surgical biopsy is not is difficult in those patients who has multiple comorbidities, and therefore flexible bronchoscopy is one of the modality that we can use as a pulmonologist. However, the conventional bronchoscopy guided biopsy of the lung nodule, the diagnostic yield is very low. And when you compare to CT-guided transthoracic needle aspirations, the diagnostic yield can go up to 90%, although the drawback of this modality is always the pneumothorax. Fortunately, for the past 20 years or so, we have many new development in the area of image-guided bronchoscopy. And I think you have heard a lot about it today. And now I just want to talk to you about the most established technique and the cheapest technique. Also, I think is very one of the main modality that we use in our center, which is really EBUS guided bronchoscopy. It has a very low overall complication of 2.8%, inclusive of pneumothorax and bleeding. This technique of really EBUS guided biopsy has been developed for about 20 years ago by Kurimoto and others. It relies on the fact that many of the tumors actually has bronchus leading to it. Therefore, if you bring the probe with a guide shift, you can localize it and you can biopsy it easily and precisely using this technique. However, this technique only provides overall diagnostic yield of about 70%. Of course, we know various centers reported a different range of overall diagnostic yield. In certain centers can go up to 90%. Of course, we also know that certain lesions has higher diagnostic yield, like those bigger lesions, those with positive bronchus sign, and also when the probe is within the lesions. Consistently, the complication rate is low, of about 2.8% in many studies. If you look at the various modalities of guided bronchoscopy, one of the common feature or consistent feature that we see is always this: the fact that localization success is very high. However, the diagnostic yield is about 20 to 30% lower than the localization success. So the problem of why we can see or localize lesion, but however we cannot get a diagnosis out of it, I think there are many reasons. Two of the major reasons that we believe is the nodule airway orientation and also the problem with sampling tools. Kurimoto in 20 years ago already shown us that when the probe is outside or adjacent to the lesions, the diagnostic yield drops tremendously as compared to when probe is within the lesions. In our center, we believe that we categorize orientation of nodules to probe into three categories, in fact, into concentric and eccentric, which is many investigators categorize as within, and the last group is adjacent to the radial probe. And we believe that both adjacent and eccentric nodules has got a lower diagnostic yield with conventional sampling methods, mainly using forceps. Concentric lesion is when the probe is circumferentially surrounded by the tumors. So in these scenarios, it is very easy to biopsy, and conventional methods actually provide a very high diagnostic yield because anywhere you biopsy, no matter which direction, you probably will hit the tumors. eccentric orientation. This is the one that I think not many people categorize in these manners. We believe eccentric orientations is when the probe is partially covered by the tumors. However, the other part of the probe is actually in a normal airway. Therefore, you can see the probe is, this part of the probe is actually within, you can see the air in this part. The other side of the probe is actually covered by the tumors. So in this scenario, we believe that when you put in the conventional forceps, you may or may not get the diagnostic. You may or may not get the diagnosis. Adjacent oriented nodule is when you can see the airway wall is still intact, maybe infiltrated by the tumors. However, in this scenario, as we can imagine, the forceps biopsy will give you a much lower diagnostic yield. Therefore, we believe that in eccentric and adjacent lesion, we need different methods of sampling, and we call it segmentation method. Hopefully, no matter where the lesion is, a biopsy, a cryoprobe is able to reach the lesions. Cryobiopsy has been there for many years, as all of us knows. This is just to illustrate the point that I mentioned as lateral 360 degrees circumferential lateral biopsies. When you activate the cryoprobe, no matter where is the lesions, it doesn't matter. You will be attached to the cryoprobe and you can get a good tissue. Let me show you this case of a 60-year-old man who is a smoker of 60 years. He presented with 2 weeks of cough and there is a lesions. Because of high malignancy risk, he underwent biopsies. There's no other lesions and there's no other significant clinical sign. However, CT guided biopsy unfortunately didn't provide a tissue diagnosis. So the patient is being referred to us. We look at the CT ourselves. This is a way that we do. We normally don't use navigational bronchoscopy. We like to use conventional reading of the airway. And it is very obvious that the lesion is arising from the RB2. And if you look at the airway, in fact, this is quite an easy target to biopsy using radial EBUS. The lesion is arising. We conclude that the lesion is arising from RB2B1. When we do cryobiopsy, we usually will get our anesthetist to be involved, to give sedation, deep sedation or DA, as well as to have artificial airway access, either mainly using endobronchial tubes. And we usually connect this endobronchial tube to a blocker multi-port adapter so that you can insert bronchoscope, ventilations, and also endobronchial balloon through this, through this adapter. Of course, you also can use rigid bronchoscopy. We routinely use fluoroscopy as well as endobronchial prophylactic balloon. So the initial bronchoscopy is usually done to ensure that there is no other lesions and can be seen, and also to identify the target bronchus and have an idea of how difficult can it be to assess the lesions. So after that, we verified the lesions using radial EBUS. So this is quite a usual procedures. So once the lesion being identified, we pull out the radial EBUS probe and lift the guide shift there. And we can start the procedure of cryobiopsy. Cryobiopsy is usually being railroad into through the guide shift. Sometimes we do not use a guide shift in some cases. And under fluoroscopy, once the position is confirmed, then we activate it to 3 or 5 seconds, depending on the procedures. And the biopsy is removed en bloc. and a good tissue is usually can be obtained. And it is very important to put in the prophylactic balloon to control the bleeding, just like when we do it for ILD cases, peripheral lung, diffuse lung disease. So in this particular case, the diagnosis is adenocarcinoma. Now, if you look at the literature up to 2019, there are not many actually. One of the first prospective randomized small numbers of patients come from the German groups. It shows that cryobiopsy is not significantly different from faucet. And other series also shows that the cryobiopsy and faucet more or less give you the same yield. Maybe certain studies has got a higher yield for cryo, but it's not certain. We look at our data of radial EBUS from December 1916 to 2018. There are 76 faucet versus 38 cryobiopsies at that time, and certain patients are being excluded for these reasons. We use a standard faucet. At that time, we do not have a mini cryoprobe, and the biopsy sequence is usually start with faucet, then followed by transbronchial cryobiopsies. And in this series, in this retrospective series, we demonstrated that cryobiopsy is only useful in those lesions which is eccentric or adjacent to the probe. In those lesions which is concentric to the probe, the use of cryoprobe, the yellow part, does not further significantly increase the diagnostic yield. Recently, Kurimoto from Japan actually showed a very large series of consecutive patients undergoing conventional versus cryobiopsies. In this series, the overall diagnostic yield is very high, of almost 90%. And however, there is not much difference between conventional biopsy technique alone versus cryobiopsy alone of 74/81%. There is only about 22 lesions that were diagnosable only by cryobiopsy, and that improved the diagnostic yield of about 8.6%. Similar to our studies, their studies also demonstrated that the advantage of use of cryoprobe was mostly apparent when the lesion is adjacent to the radial EBUS. And the diagnostic yield in this group of patients improved from 69 to 84%, which is quite similar to our studies. Severe hemorrhage happened in 1.2%, no mortalities, and pneumothorax happened in 2.8%, which is consistent with radial EBUS biopsy. So lesson learned, cryobiopsy probably is not useful for every single nodules. It is, for us, we believe that it can be useful for adjacent or eccentric nodules, not for concentric nodules. Now let me talk to you about the second scenario that we believe cryobiopsy can be useful. This is a case that the lesion is in right upper medial segment, the medial part of the right upper. And most of you will understand that when the lesion is medial to the target bronchus, sometimes it can be difficult to target or to direct the biopsy faucet towards the medial part of the lung. If the biopsy faucet usually tend to go laterally because of the rigidities of the faucet. So in this particular case, we use the extended working channel of the electromagnetic navigational tools because of the ability of it to curve in certain directions, and coupled with a mini cryoprobe, then we are able to reach the medial part of the medial part of the lung and successfully to get the biopsy samples. So the lesson number 2 that we think cryoprobe can be helpful in those patients, of these scenarios where where the lesion can be difficult to reach using the conventional tools. Now, we all know that bleeding is a complication of cryobiopsies. And it is also in our experience that when the lesion has got a very small arteries, surrounding the lesion biopsy, the bleeding risk is usually very low. However, when the lesion is adjacent to quite a big vessels, like in this particular case, more than 5 millimeters of airway of the vessel, resulting in a significant bleeding required tamponade for about 50 minutes. So lesson number 3, we believe that those patients, those lesions who has adjacent vessel which is of significant size should not be attempted using cryobiopsy. Yeah, other limitation of cryobiopsies, is certainly compared to simple radial EBUS, is more labor intensive. Probably not that labor intensive compared to other modalities like, or costly compared to other modalities like Colombian CTs and robotic bronchoscopy. However, you still require fluoroscopy, balloon, and cryo machine and advanced airway. And certainly it got a higher bleeding risk, as we all know. In our cohort, as compared to forceps biopsies, cryobiopsy significantly, has got a higher risk of bleeding. Fortunately, most of these bleeding are mild and moderate, and there's no severe bleeding. Pneumothorax risk, of course, is quite low. And therefore, it is our belief that prophylactic balloon should be always used, just like in the case of IOD. So this is our approach to lung nodules. In our centers, we do not have all the modalities as compared to the developed nations. We mainly rely on radial EBUS, ultra-thin, and peripheral TBNA, and also some navigational, electromagnetic navigational bronchoscopy. And we believe that most of the, in those patients who has a good lesion, concentric, radial EBUS probably is enough. In those patients who the lesion is in a very high, very far away, ultra-thin bronchoscope may be useful. Of course, there are other methods that other speakers already taught to you. When there is no bronchus signs, of course, BTPNA, but we do not have BTPNA at the moment. So sometimes we employ peripheral TBNA and can be successful, although I do not have time to talk to you about this. And for those lesions that is adjacent to the airway, we believe in certain patients, transbronchial cryobiopsy can be very helpful in this case. Of course, sometimes transbronchial peripheral TBNA also can be useful. So in conclusion, ladies and gentlemen, I just want to say that cryobiopsy can actually further improve the diagnostic yield of radial EBUS, especially in those lesions which is adjacent or eccentric to the radial probe. However, the advanced airway and prophylactic balloon should be used as a standard for any cryobiopsy. With that, I thank you, and I welcome any questions or discussion or comment from the audience and other speakers. Thank you.
Thank you, Dr. T. Sutek, for an excellent talk on the role of the cryo in peripheral pulmonary lesions. So we have heard so many lectures from the different speakers, and to sum it up on when, what, and how to choose in the management of peripheral pulmonary lesions, we have Dr. Thomas Gildia. He is the head section of bronchology in Cleveland Clinic in USA. So he will be guiding us on how to choose the tools that are available in the armatorium and how effectively we can use these technologies in approaching to a peripheral pulmonary lesion. Over to you, sir, for this talk.
Thank you very much for the opportunity to come and speak to my friends in India and around the world. I have the great honor of closing down this session, and I'm going to try to do my best to summarize some of the lectures that you've just heard and discuss the when, what, and how to choose different modalities in the management of peripheral pulmonary lesions. And so this is a beautiful picture of Cleveland, certainly far smaller than the cities you're used to seeing, but we do get some nice weather every now and then. So as a means of disclosure, I'm a consultant and I've been on the scientific advisory board and an investigator for many companies, including Siemens, Medtronic, Ethicon, J&J, Intuitive, some of the manufacturers of all the different machines that you're going to see here. So I should hope to be at least in some ways universally conflicted, which I think in some ways helps. But I am biased. I do have certain expertise and many years of training in this field. So my biases will be evident, and I hope to disclose them so that you can understand where I'm coming from. So this is a picture of my bronch suite from a number of years ago, and it was sort of done more as a photo op to show folks that advanced peripheral biopsy is certainly not what it used to be. And if I were to retake this picture now, there'd be several new pieces of equipment in the room. But the concept here is that it's multimodality. It is clearly an interaction between sort of advanced peripheral imaging, sort of in the case of the peripheral ultrasound you see. I have a navigation system in the view here. I also have fluoroscopy going. I'm doing this under general anesthesia. And then I have multiple ways of interacting and looking at the CT scan and other images during the course of the procedure. So this field has been rapidly evolving over a long period of time. And certainly the concept here is that it's a modular approach to these things, at least it is in my bronch suite. So what you've heard from the prior lectures is a lot of talk about individual technologies, but it's important to point out that there are so many other possible factors that may be associated with the yield of a peripheral lung lesion and only one of them is the technology. So we do know from data that there is a difference in yield for lesions bigger or smaller than 3 centimeters, and other studies have broken it down in 2 centimeters. Folks have tried to describe the location, whether it's the inner 2/3 versus the outer 2/3 or outer 1/3. There might be some variance you see in the literature about lobar distribution. Some lobes are easy to get to others, and I would say that that's qualified based on, say, obesity and evidence that we're seeing with atelectasis. Lower lobes tend to be somewhat different. And other locations, we can talk about how many generations off the airway is, and we've had challenges around things on fissures. The anatomy seems to be important. Clearly, the evidence of a bronchosine has repetitively been shown to be associated with yield, even in the pre-advanced bronchoscopy stages, that we knew this even from basic bronchoscopy many decades ago. Certainly some new evidence about what kind of biopsies you take. And certainly we know that TBNA for the longest time has had the highest yield, although forceps are probably just about equal depending on the study you look at. But also there's value to brushes, needle brushes, the triple needle brush, aspirates, just simply aspirating at the lesion has been shown to be better than a transbronchial biopsy. There's new technologies like the GenCut needle, and you've heard about a lecture about cryobiopsy, all contributing to the yield in and above the technologies that you looked at. No doubt there's a major impact about how the specimen is managed. And certainly, depending on the hospital you're in, you may have a dedicated cytopathologist versus histopathology. In fact, there used to be literature written in great detail about only histopathology can be used to make a diagnosis. And yet in my center, very rarely histopathology is used anymore. It's really cytopathology and histopathology sort of as a secondary, but really everything goes off to molecular markers. There's some studies being done and guidelines written about small samples versus core. Interestingly enough, there's very little data around what exactly a core is, particularly in the EBUS literature. So it'll be interesting to see how that may play out in bronchoscopy of peripheral lesions. Immunohistochemistry continues to evolve, as does molecular analysis. And then we talk a lot about ROSE, which is the cytopathologist giving merely an assessment of adequacy, but in my institution, we have super ROSE, as I call it, where I actually have a cytopathologist reading the diff quick stains and telling me whether I'd have non-small cell or small cell cancer so we can triage the specimen. Undoubtedly, there's an operator expertise and support team expertise. All of us have been in situations where you know your instrument, but the people helping you are really struggling. Again, I talked about cytopathology expertise. Some pathologists moonlight as lung pathologists, but they do everything else. In certain centers, you could have experts in just lung. And again, we talk about image localization. So if you talk about, say, cone beam and cone beam CT fluoro, virtual fluoro, and fluoro in and of itself, there are some centers that are actually quite worried about fluoroscopy. And yet we know that it takes like 50 bronchoscopic procedures with fluoroscopy to equal one cardiac catheterization example for radiation exposure. Navigation can be done virtually with electromagnetic or shape sensing, as we saw in the robot literature. And then lesion confirmation seems to be useful, again, more as a post hoc or a sort of after the fact confirmation using radial ultrasound, but also folks have looked at things like confocal and probe-based light endomicroscopy. Certainly there is very high interest now in anesthesia. All of our procedures are now performed under general anesthesia with an endotracheal tube in so that we can deliver high volumes and high peeps and low FiO2 because we're really managing the lung and managing atelectasis now. Certainly we've seen evidence where rapid intubation, if not done properly, atelectasis sets in very, very quickly in obese patients. And atelectasis occurs in high proportions, and we've seen that in the cone beam data. And then some folks swear by using an endotracheal tube versus LMA. In our center, some of the anesthesia folks have problems with LMAs because you just can't maintain the high volumes and high peeps in some individuals. Again, EBUS as a standalone or peripheral EBUS as a standalone is a technique that is very valuable, and you could use it with or without the other technologies. And certainly I mentioned again and again obesity. And interestingly, obesity makes biopsies very challenging in the United States, but conversely, the more severe your lung disease, the more emphysema you have. We've noted that the lung does not move, does not collapse, and those actually procedures are easier from a navigation standpoint. So just to summarize, there are so many other factors that go into determining how well any technology will work on and of itself, but recognize there are so many other unaccounted for pieces of the decision-making process that goes into how these techniques are used that is not commonly reported in literature. So with that, just remember, again, you talked about peripheral ultrasound guided. That could be done with a sheath or with a small scope. We looked at virtual bronchoscopy with lung point. We looked at CT guided bronchoscopy, EM navigation bronchoscopy, ultra thin bronchoscopy was very commonly used in Japan. And those Japanese authors were quite good at this. And now we've got robotic assisted technologies, as you heard about today, and then combinations of the above. Again, this is just a video showing some of the features of electromagnetic navigation bronchoscopy. And just again, you saw these literatures today about how individuals learn to operate and drive. And just as a point of education, in this video, we're showing that you have to drive to the line and not necessarily to the target. And again, this is the old version of Super D. There's now a new version of Lumicite. This is with the newest version with the Lumicite. We're doing this process of basically augmented fluoroscopy. This is the Lumicite, and we can do these addition of augmented fluoroscopy to the images. Those little tungsten seeds are moving around, so the computer is getting a three-dimensional or tomosynthesis of where the lesion is. And then it processes. And now we've got an ability to go ahead and do a further registration on the target lesion. And there's a number of different steps here. I think I'm just going to cut through because you probably had a lecture on this. Again, this is a picture we call tomosynthesis, where you can outline where the lesion is and get a good view of it. And this is further registration to improve the yield of the lesions. Now, I want to point out this, that these instruments, all of them are tools, and they are all subject to skill acquisition. The data is universally weak, and there's a later editorial about this because of the extremely large number of uncontrolled and unreported covariates, as I described, and there's precious little comparative data from one instrument to the other. There are myriad and local and systemic variables that make any study done at any individual or even small clusters of centers very universally adoptable by other centers across the world. And of course, as you may have heard, and what my partner always says, the best system is the one you have, and I would add to it the caveat, and learn to use well. Then the pictures below are just a probably uniquely American thing, but a chainsaw is a tool. And used in the right hands, you could make enormous, beautiful pieces of art, but you give it to an amateur and you drop a tree on your house. So recognizing that these things are instruments, they're tools. I could have easily put up a musical instrument here showing, say, Yo-Yo Ma with a cello and showing a 5th grade student with his cello, recognizing that years of training, expertise, and practice are the key to making that instrument work well. Now, to get to the point of this lecture, I put together this advanced bronchoscopy matrix, and this is really based on, I can't remember if I gave this lecture at the SAB or AABIP or CHEST, but the idea here is that when you look at different instruments, there's a capital cost and then there's a per use cost. And then I put on the right some mentions of sensitivity and yield and that sort of stuff from literature, not to go over it again, but ultra thin or radio ultrasound with fluoroscopy is probably the most inexpensive option, and per use is very inexpensive. Again, if you use a catheter based, the real costs are the catheters and maybe your biopsy tools, depending on which tools you use. And then really it comes down to capital cost. If you're using an ultra thin scope, that's certainly far more expensive than if you were to buy a peripheral ultrasound probe. In the United States, a peripheral ultrasound probe runs about $5,000. An ultra thin scope runs about $30,000. Electromagnetic navigation system and Varon, I would say they're essentially equivalent. Capital costs are fairly high. I don't even know the cost these days, probably around $200,000, probably slightly less. But there's a significant per use cost. Every time you use one of these instruments, you have the disposable navigation sensors, and those can be add up with the catheters, and there are basically parts to these things. The same is true for the Varon. Depending on what series of instruments you use, they can be costly. And again, both of them may require a new CT scan, which can add to the cost unrelated to the technology. And you can see now that there's yield is increasing. The most recent data showing that the augmented fluoroscopy version, the new version of Superdimension Illumisight, has about a 25% or 29% increase in yield over the prior V7 system. So that independently, there's a first study comparing one system to the other showing increasing yield of the new version. The robots, which are very exciting right now, hot technology, they're very expensive capital costs, depending on where you are. There are some institutions that have different cost structures because of other technologies. And then the per use costs are quite expensive too, but we don't fully know this yet. I know some centers that have much more experience on per use costs, but the robot scopes that we use are essentially one use per patient, and then they go back to the manufacturers trying to figure out ways to clean them and reuse them. But right now it's one shot per use, and then you have to buy all the other additional pieces. Cone beam CT capital costs, if you were to buy one of these outright, it's several $1 million. However, most of these exist already in your hospital. And so again, you may decide whether or not putting a GE system or a Siemens system or Philips system is worth your effort. Per use cost is quite low. It really comes down to what technologies you use in conjunction with the cone beam CT. So for example, you could be very expensive using cone beam CT with electromagnetic navigation, or you could use it sort of as cone beam CT with peripheral ultrasound and fluoro or catheter-based systems. And then certainly there are many others, and we don't have time to go through them all, but there's virtual navigation platforms. There's a mobile CT I'll show you a little bit about, Archimedes, the transpulmonary biopsies, and then augmented fluoroscopy I'll talk a little bit about as well. And again, you could recognize here just in the yield matrix, the yields are all over the place. They can be in the 70s, they could be in the high 80s. Dr. Pritchett, I'm sure, has shown some of his data, which is really outstanding. But really, that's not 100%. So anytime that you see numbers this high, they're very, very good, but it's not universal. And again, it can vary quite vastly based on other factors as I've discussed. So this is just the first picture of cone beam CT. And in this version of cone beam CT, the very first description, it was really just a regular bronchoscope and they were fishing out a biopsy forceps. There was no catheter based, there was no ultrasound, it was just a catheter based. And so again, looking at it, you can think of all the different problems with it. This is the Cleveland Clinic version of cone beam CT, and actually we've moved from this platform to a new platform. This just gives you a sense of how fast the spin, and this is the robot arm version of cone beam CT, the Siemens unit. You can see that it's a very fast spin around the patient. But what to point out about this is that even though we have this technology, I can see exactly where I am. And here I have a picture of, this is a needle in a pleural-based lesion. Look how small that is, but the needle's in it. I have a brush into this lesion. I have forceps in this lesion. I have a triple needle brush through this ground glass opacity. I don't think there's any question that this, and this are all in the lesion. The problem is only this one was diagnostic. And so if you were to go and make a statement that, oh, cone beam is so much better, I can say that, hey, cone beam is great. I can see my instruments, but it didn't necessarily change my yield because only this was sufficient to give me a biopsy. And we could argue then say, well, needles are better than forceps and forceps are better than needles, but only the brush got the biopsy in this particular case. So it's not all one thing. It's not all one piece of the puzzle. This is a version of the mobile CT. This is, it's actually not a mobile CT. This is actually a fluoro unit. This may or may not be in your hospital. This is the newest generation of Siemens C-arms that are actually used most commonly in neurologic surgery or orthosurgery. And this particular C-arm has a 12-inch flat screen detector, and it also has a ability to rotate around the patient. And so in the procedure, you can get three-dimensional reconstructions. And so this is what it looks like. This is from a little paper we used to describe in the JOB a year or so ago. And you can see first it starts off with a manual rotation around the patient. And this is pre-COVID times. You see that we're not wearing N95 masks. And you see we manually move this around the patient to show that the arm has a good swing. And then we go ahead and let up my fellow. And then you see we'll turn on the rotation movement. And it's really just moving around the patient, slowly taking images, individual snapshots. And then the computer will do a tomosynthesis or pull those images together and do three-dimensional reconstruction. So it's a relatively slow process, but it does give you three-dimensional imaging and three-dimensional reconstruction capacity in a portable system, which is a fraction of the cost of, say, a fixed unit CT scan. All right, let's see how I can get at it. And you see when we do this particular procedure, I can get quite good. You can see here, I thought I was on the lesion, but I'm actually passing underneath with a needle. You can see over here, I was actually sampling this needle. You can see the needle in the lesion on two different views, but you could also see the interesting evolution of atelectasis setting into this patient's upper lobe. And in fact, in this view, you can see the upper lobe is disappearing quite quickly and the lesion is barely visible. In this case, severe emphysema, and you can see I was able to get the edge of the lesion with the needle biopsy on the extreme periphery in a very small lesion. So it is a useful tool. You can get three-dimensional reconstructions. You do get the ability to confirm where you are in real time, used with other technologies and in a portable system. However, I just want to point out this, that no matter what system you use, these are not necessarily real time. So we saw some of the stuff with cone beam CT, but you'll see in this image, my forceps don't match the airway because my catheter here, my forceps were stiffer than the airway that it was in, so it straightened it out. And also when I play this again, recognize here's the diaphragm, and the lesion is somewhat represented by this. It's not necessarily fluoroscopically visible. But in this view, the diaphragm is moving, but the target is not, and that clearly can't be the case. So even if I'm using augmented fluoroscopy, I'm using a version of cone beam CT here, I am distorting the airway, and the lesion is not necessarily tracking with the overlays, which is different from some of the other stuff with the augmented fluoroscopy. And so this is a video, I'm gonna try to show you this. This is body vision. Again, this is a catheter-based augmented reality type situation. And what's really cool about this technology, again, you're getting the CT overlay, you're getting a three-dimensional overlay and trying to use this catheter to follow on, but you're navigating in two-dimensional space. But at least here you're seeing the assessment of a lesion movement. So this is an AI-based software algorithm to show the lesion moving in real time, which I think is a remarkable piece of technology. It's still part of other pieces of technology, but that's what the augmented fluoroscopy looks like. Again, we talked about robotics. There are two systems available in the United States. I know there are other companies working on other versions of it. We've got the RS Monarch on the left and the Intuitive Ion on the right. Both of them have their pluses and minuses and some things about how they work in your hands. But just to point out a couple of key features. So on the RS Monarch robot, for example, this is really just a great big bronchoscope. It's a 5.9 millimeter outer diameter sheet, 6 millimeters, with a 4.2 or 4.4, I think it's now the newest version of it, 4 millimeter, inner bronchoscope with a 2.1 working channel. And what's unique about this is that basically you're driving a thin bronchoscope deep into the lung with navigation, with the ability to control the distal end in a highly precise way. So it's really a navigation system. And in the case of RS Monarch, it's a combination between a visual representation in the algorithm to tell location and electromagnetic navigation. But it's really a very large bronchoscope to a point, and then it becomes a small bronchoscope as it extends beyond. One of the real values of this technique, however, is the key of how precise you can be. So this is just a video about being deep in the lung with a fiducial marker. You see we have remarkable control in the distal end of the scope. And more importantly, when you're trying to get at a lesion and you have vision, we can drive this needle right up to a very, very precise point in space. So if you, again, you have some sense of ultrasound guidance about what's beyond the wall, or external imaging guidance, or virtual guidance, if I know exactly where the target is, I could line up the needle or biopsies extremely precisely, until of course any blood or something that occludes the lens. But the idea here is that it's an enormously a valuable asset, I think, to be able to have this much control in the distal end of the bronchoscope. How that's going to play out in the literature, we're still learning. Now, are these good enough for therapeutics? Now, this is just an image of microwave ablation in a swine model, actually using the mobile CT unit. You can see here a ablation catheter through a lesion, and you can see after a few minutes there's an ablation zone around it. So these technologies are being evaluated with the concept of doing ablation techniques, and Dr. Pritchett has experience in this field. And so hopefully we'll see some evidence of these technologies being platforms for therapeutic interventions. So pros and cons. Bronchoscope with EBUS, the pros are they're relatively less expensive depending on your fleet. We've got 15 years of data. It is highly dependent on the operator skill and the navigation skill, and is done typically without guidance, but it can be combined. So if you have other instruments that you can buy or get into your system, they can be very valuable. The Japanese have shown that this is an excellent skill in their hands. They've published on it extensively. The cons, that you're limited by the size of the scope or the catheter. So if you're using an ultra thin scope to go deep in the lung, well, then you've got a very, very small catheter to work with for your biopsy instruments. If you use a catheter-based technology, then you're not really seeing anything when you're deep in the lung. And it typically requires other guidance. So in our institution, it's almost always ultrasound. And there's some data from Alex Chen and others with the peripheral ultrasound. Although they can identify them 95% of the time, their yields drop. And so we're some sense, and we've seen this with cone beam, that there's a false positive sign, that when you get atelectasis, you can have what looks like a positive ultrasound finding, but it's really a false positive because atelectasis is set in. Electromagnetic navigation. So although it used to be a new technology, we have over 10 years of data. The newest version has integrated augmented fluoroscopy. We can add ultrasound and other local imaging tools and peripheral cryobiopsies. It's a platform-based technology, catheter-based. The Varon system does have distal vision in one. The Super Dimension does not have distal vision in the other. And it can be used for lots of things. Transpulmonary dye marking. They've got a cross-country needle similar to the Archimedes system, where you can actually perforate the airway. We've seen fiducial placements. They're working on ablation. The cons is that they're relatively expensive on a capital side, and they're certainly expensive on a per-use cost side. Skill is very important. Super D is blind, although Varon does have vision available. There are many, many variations, too many even to go in. When we first did this procedure, it was under sedation. Now we do them under general anesthesia. There's certainly shown value of the anesthesia techniques, and the real world data, and there are quality extremes. If we look at the Acquire registry data, where the yield is profoundly low, again, that was a real world experience, choosing it only when they had to. Yields were very, very low, but in the real world, when we chose and selected patients, we had much better yields. And so that becomes considered a bias. Catheter-based systems are passive. So unlike the robot where I have distal control, the passive catheters can be a challenge for some, and others, people get quite good at it. Cone beam CT. Again, this may already exist in your hospital. So if your hospital has an interventional radiology department or a vascular surgery department, chances are they have this technology. It's just a matter of you getting time there. You do have the ability to do real 3-time confirmation, and you do have the ability to do augmented fluoroscopy. You could do a virtual target on the screen. That's built into some of the systems, but again, not all of them have that software. It could be used with or without any guidance systems. There is a mobile system that I showed, but that version does not have augmented fluoroscopy. I can't project on that screen yet a virtual target. A starter version for a con, just to get a refurbished unit starts at about $1 million, and you have to build construction for a control room. For a fixed unit, mobile units, you don't have to do that. Skill is clearly important. It's dependent on the guidance system. So if you're a lousy guidance person, you struggle with 2-dimensional guidances, you may struggle. And at some point, there's some historical imaging. Again, there you saw the picture of the diaphragm moving with the target knot. These are not, there's a real-time fluoro, but they're not real-time augmented fluoro. You don't see exactly that lesion like you do with the body vision. And some people have radiation concerns, although the radiation for these are actually lower than standard fluoroscopy in some cases, because the time is so short, and we could really cone that down quite a bit. Robotics, peripheral and fixed control, we can add ultrasound and other imaging technologies. The vision and the navigation is integrated. There's 2 different versions of that system. These clearly are platforms. So although right now they're built for biopsies, clearly on the horizon is the ability to do ablation or other techniques. These are relatively expensive at the moment, although probably prohibitively so in many circumstances. The data is limited but evolving. We don't have a great sense of the learning curve yet, although hopefully we'll figure some of that out in some of the new trials. It's not bronchoscopy. So folks who learn bronchoscopy and are learning additions to bronchoscopy, theoretically the skill acquisition is a little different, but robotic control is very different. And so that is a new thing that we have to contend with, as opposed to just adding another variation to bronchoscopic management. And there are space challenges. These instruments are quite big and they take up space, and most bronchoscopy suites are actually quite small. So just to get close to the end here, I just wanted to put a few things out there. So this is an article, an editorial I wrote a number of years ago that talks about fancy technologies, and there's authors from around the world. When you look at studies and study designs and the modalities, you can look at virtual bronch and ultrathin, where Dr. Asano in Japan, as I alluded to, can really get to lesions 95% of the time just with a virtual bronch and ultrathin scope, but their yield dropped down to 82%. And in almost every one of those cases, it was a biopsy alone technique. When you look at GEX, when they did a meta-analysis, all the nav bronch, our success, our ability to reach lesions or get there was 97%, although, albeit this was to a virtual target, the yield dropped to 70%. When you looked at Chen's cohort study, radial ultrasound, 95% success in finding a lesion, 68% yield. Ashita randomized controlled trial, virtual bronch versus virtual bronch with radial ultrasound, 93% success in finding the lesion, 80% yield. The pilot study cone beam, 91% success getting there, 75% yield. Park cone beam CT, 72% both ways. The concept here is it doesn't matter what technology you have. It doesn't matter the study design, but recognize within each of these studies, there's different variations, and we have success in the ability to get things, but the yield drops off. So that's all those other features we talked about in terms of getting the right instruments, right kinds of biopsies, are they handling the specimens properly, on and on and on. So just be aware of that as when you're choosing this technology, is recognize that every one of them has been shown to have this diagnostic drop. So there was an article, editorial written recently, that was commenting upon one of the navigation studies. And Dr. Tremblay and colleagues in Canada said that we're flying despite our best instruments. So they said that the methodologically soundness of these trials is great, and they went through how you report peripheral nodules, but we don't have a lot of comparative data to really understand that which instrument is better than any other instrument. The very few studies we have show them to be quite similar, and in fact, the one comparative study with one version versus the new version of SuperD, the new Illumicite, is clearly better than the old one. And that's rare, even in our specialty, to see that kind of instrumentation data. So we have all these great tools. We see individual study data, but we don't have all the details that I would like to see when I'm trying to make this decision. So the final word, all systems have similar navigation and localization success in the trials, but the diagnostics drop clearly suggests that there are other factors at play, and I try to go through an exhaustive list of those for you to consider. The best system is the one that you have, and that you figured out, and that you know how to select your patients and you know your limits. Dr. Sassini, my partner, says the best system is the one you've got, and I would say it's the one that you've learned to use well. Based on the current limits, to decide the best tool to address it, there's this idea of implementation science. So anytime you see a trial and you want to buy a piece of technology, you really have to get into the details of how that trial was done and see if you can replicate the scientific methodology in your patient selection or into your procedure. So for example, if you buy an electromagnetic navigation system today and you start to use it and you say, well, I don't use general anesthesia, don't expect the same results. You really have to mimic and match all the parts of the trials to see. Training for expertise. Dr. Hans Lee in the United States has headed up some of the work around training programs, and clearly there's training involved. You can't just buy these instruments and expect to be good off the bat. These are instruments, these are tools, these things that you need to learn to use. And then capital purchase is really a business decision. These are not really clinical ones. I can't come to you and say that this technology is clearly superior to any prior technology. This really comes down to working with the business leaders in your organization to make a business decision about an investment, and then using that investment with you and your team to make this thing work in your hands. And then, of course, you have to align the clinical needs with the business decision makers. If you're practicing in a cancer center and you are obligated to go after peripheral small lesions, and I would imagine in India, there's a lot of tuberculomas and other benign diseases you need to contend with. In the United States, where I am, it's histoplasmosis. Recognizing which instrument you're going to use, align with the business decision makers in your institution, and then make a decision based on what's appropriate for your group. So with that, I'll stop and allow the panel to take on any further discussion or entertain any questions they may have within your group there. Thank you very much.
Thank you, Dr. Thomas Gildia, for summing up the advanced modalities which we currently have in the approach to the peripheral pulmonary lesions. This is now followed by a panel discussion on how we are going to implement these modalities and the existing modalities that are available in the Indian scenario. So to moderate this panel discussion, we have Dr. Karan Madan. He is an associate professor in the Department of the Pulmonary Medicine and Sleep Disorders at AIIMS in New Delhi. Over to you, Dr. Karan Madan, for carrying out this panel discussion. And I would request you to introduce our panelists as well. Thank you.
Okay, so a very good evening to all of you, and it's indeed a pleasure to be chairing this panel discussion. I would like to thank Dr. Vishweshwaran and the entire team from Yashoda Hospitals for inviting me. This is a very important topic, and we'll have opinions from an esteemed panel of panelists here. Most of our colleagues, we've known each other for a long time. And the title of this discussion would be Approach to Peripheral Pulmonary Lesions, especially in an Indian or a resource-limited context, which may be there in many settings. I would like to briefly introduce my co-panelists. We have Dr. Nagarjuna. He is a consultant pulmonary medicine at Yashoda Hospital, Somajiguda, Hyderabad. Dr. Hari Kishan, he's a consultant interventional pulmonologist at Yashoda Hospital, Sikandarabad, Hyderabad. Dr. Kedar Hibre, he's a consultant pulmonary medicine at Narayan Hyderale, Bangalore. Dr. Umang Shah from Pranayam Heart and Lung Center, Surat, Gujarat. Dr. Yugandhar Bhattu and Dr. Vishweshwaran, both are consultant pulmonary medicine at Yashoda Hospital, Malakpet, Hyderabad. And I'm Dr. Karan Madan. I am an associate professor of pulmonary medicine at All India Institute of Medical Sciences, New Delhi. So I just give a brief outline to our topic. We are discussing approach to peripheral pulmonary lesions in an Indian context. The settings are a little different from the West. We deal with a lot of healed changes, fibrotic scars, post-TB sequelae, granulomatous conditions. A lot of entities which present maybe as peripheral pulmonary lesions, in addition to the malignant causes which you have in most of the settings worldwide. So the approach in our setting may sometimes be a little different. We might have to take into account the clinical radiological profile and get into the decision making. And we have primarily two approaches which have been the outline, the cornerstone to diagnosis. One are the image-guided percutaneous biopsy approaches, which is primarily a CT-guided biopsy approach, and then the bronchoscopic approaches, which have evolved tremendously over the last decade, I would say. So I think to begin this discussion, we would have a small case discussion. Dr. Nagarjuna would be presenting one case and just showing us how he dealt one case and a diagnostic algorithm. And then we'll have, a few issues we'll discuss on multiple aspects regarding peripheral pulmonary lesions. So I think I'll hand it over to Dr. Nagarjuna to present his case, and then we'll take it forward.
Thank you, Dr. Karan. After the excellent talks by the faculty, so we'll be just discussing one of the cases wherein we had used the only navigation platform we had, that is the VPN. So this, I'll just briefly discuss the case. A 70-year-old gentleman, he was a retired employee, known hypertensive, diabetic, coronary artery disease, post-PDCA status, so multiple comorbidities. He was evaluated for abdominal symptoms and was diagnosed to have a carcinoma stomach. So basically, he had come to our hospital for curative intent gastrectomy. And as a part of his pre-surgical evaluation, a PET scan was done. And PET scan showed two things. He had lymph nodes, paratracheal and subchoroidal lymph nodes. And he also had an incidentally picked nodule in the right middle lobe. I'll be showing the images of this. This was also FDG-AVID. It was actually showing the SUV max of 5.7. And lymph nodes were showing SUV max of 4.3. So this was where the whole confusion came, whether to go ahead with surgery or not. So he was referred to us for evaluation of these lymph nodes and this lung nodule. So because it's a small nodule, Albish was showing the CT images. So this was the CT images. As you can see here, this is the parenchymal cuts. You can see here the small lymph node, and this is the nodule here. You can see the nodule, the right middle nodule. The good thing was we could also identify a small bronchus actually going into this nodule. So this actually had a CT bronchus sign. He also had some mild broncholectatic changes and some infective changes in the left lower lobe. So with this, we had to decide whether to go ahead and attempt this nodule biopsy or not, because it was less than 8 mm, but because it was FDG in the presence of an active malignancy elsewhere, extrathoracic malignancy. The mediastinal lymph nodes was straightforward, we could do a linear rebus. So then we decided to actually plan, because it was a very small nodule, rather than going in blindly with the radial rebus, we decided to plan our approach using the virtual bronchoscopic navigation. So this was the VBN planning. So this was the nodule which we had marked on the VBN system, and this is again one of the reconstructed images which showed the path actually going right into the nodule. So this is a video. I'll try to play the video. Sorry for the audio there. So this was the path of the virtual bronchoscopic navigation going into the right middle lobe lateral segment, and you can see it's a head-on path, because CT also was showing that this thing, and we then did a radial rebus. Radial rebus showed a nice concentric image, brushing and biopsy were performed, and linear rebus also was performed. So in this particular case, Rose did not yield any atypical cells, but transbronchial lung biopsy revealed incidental finding of a neuroendocrine tumor. Linear rebus was consistent with adenocarcinoma, which is probably metastatic from the stomach. So diagnosis of synchronous metastatic adenocarcinoma of stomach and a carcinoma tumor of the lung were done. Nevertheless, he became unresectable because of the positive subcarinal node. But this is one of the cases where a small peripheral pulmonary nodule was biopsied using a combination of a navigational platform and a radial rebus. So this is one of the cases where we could actually have a good path which was shown, but it is not always true. Many times we won't get a head-on path. I think that we will discuss as to how to approach in the further panel discussion. With this, I'll stop sharing.
Yeah, thank you, Dr. Nagarjuna. It's an excellent case. You know, it brings us the challenges of a small pulmonary nodule, and in this case, you did get a different etiology for the nodule apart from the lymph nodes. This highlights one fact that, you know, if you still have mediastinal lymph nodes, those should be sampled first in the setting, because more likely than not, you are going to get a malignant diagnosis much more likely, and with a shorter duration time procedure than the lung nodule. And, you know, with the navigation, you were able to get the diagnosis of coexisting carcinoid tumor. So just for that, was it? It must have been a low grade, you know, carcinoid, like a grade 1 or something.
Yes, it was a low grade carcinoid. In fact, we had not done anything for that. We just left it as to follow up on the.
Yes. Right. So I think maybe I'll just put a few questions to the panelists, take this discussion forward in the light of these. So any comments on the case per se from anyone before we go ahead? Okay. So I think I just put a question to Dr. Hari here. So Dr. Hari, so like we saw a case here in which there is a, you know, a small pulmonary nodule located in the middle lobe. So, you know, we get a lot of patients, you also get a lot of referrals. So how do you basically choose? What is your preference of a modality for sampling the peripheral pulmonary lesions? And how often would you choose a bronchoscopic approach in these small pulmonary lesions?
Thank you, Karan, and thank you, Vishwesh, for inviting me here. So, as you said, in an Indian context in the beginning, it's not my preference for choosing. Most of the times it will be a patient preference, because most of the times when a patient is referred to us with a peripheral pulmonary nodule, already those CT scans are already done in our settings. So choosing means, again, they don't bring these scans, CDs and all, so where we can clearly go and do a thin section scans and see if bronchoscopically I can approach the lesion or not. So what best I can do in those patients is, if at all I'm choosing to do a bronchoscopy, So go with a blind radial EBUS approach and then see if I'm able to reach the lesion or not. This is practically what is happening in my setting. So patients who come to our OPD clinics and finding a peripheral nodule is very less in my practice, because I work in a multi-specialty department, not in an oncology center. And we don't have a screening program also. So that is one. Patient factors mostly also depends on in working in a corporate hospital on the budget they have, because so like if you are planning to use a bronchoscopic approach with the radial EBUS, again with a limited CT cuts with what they carry on, giving a negative diagnosis will have a lot of impact on the financial aspects of the patient. So those factors have come first in my practice where I am working when choosing what kind of biopsy, whether it is a CT guided biopsy or I'm doing a this thing. And second thing, I most of the times I also do like to do biopsies in benign nodules, mostly what we see here, like the small early cavitations in, not exactly in the periphery, maybe somewhere in the center with the early cavitation, especially those TB where the BAL come negative. That is most of my practice is biopsying those nodules with radial EBUS. That is my practice. Thin bronchoscopy, I have a 4.2 with 2 mm channel bronchoscope. That is what the least we have. So I most of the times we tend to use these bronchoscopy and radial EBUS approach only. So combining navigation, again, if the patient is the fresh patient to me, if he doesn't carry a CT scan and then on a accidentally detected this thing, then those areas I try to do a thin section scan and do a navigation bronchoscopy. So again, cost also comes into play here. So percent, if you ask me, like less than 50%, because I don't have a very high practice of peripheral pulmonary nodule clinic. I don't run that. So most of the times we have an EBUS where we do a diagnosis, but as Dr. Nagarjuna said, there will be very few cases like this will have a 2 diagnosis in one patient. That is very rare also. So most of the times EBUS will give us a diagnosis. If it comes to peripheral bronchoscopy, my options are mostly using a radial EBUS, that too on a conventional EBUS, like going and looking in which bronchus the lesion is and then trying to get a diagnosis.
Okay, excellent. So just one small, addition to that, I have a question on, in fact. So how would you basically decide, some nodule you'll go for a bronchoscopic approach or some for a image guided approach? Because, if you see the yield issues, the yield of a percutaneous biopsy would anyways be much higher than that of a radial EBUS approach. So do you kind of choose that this is the kind of nodule I would like to go for bronchoscopy, and this is one I would just send to the radiologist?
Again, before choosing this, I will discuss with the patient and also consider the financial aspects here, because giving a negative diagnosis with a bronchoscopic approach in my setting will be very expensive. So if I feel like the patient has a clear diagnosis on bronchoscopy, I have confidence in giving a 100% diagnosis of a nodule, which will overcome the CT diagnosis, then only I will try to prefer a bronchoscopic approach in these patients.
Right. So coming to Nagarjuna, if for such a, this was a nodule which was kind of very small, located in the middle lobe. I mean, and you by a careful evaluation could see possibly a bronchus sign. So you went ahead. So would your approach be a little different or on the similar lines, or would you like some nodules to just go to the radiologist?
See, how we do is there are 2 very strong predictive factors. One is the presence of a bronchus sign. So if a CT is clearly showing a bronchus sign, then definitely a tendency towards going in for a bronchoscopic approach would be there. 2, in our setup still, if we have a nodule which is touching the pleura or visibly close to pleura, where you can actually do a CT guided biopsy where there is no rib blocking it or something like that, majority of times we end up sending it to the CT department to get a CT guided biopsy done. If they're not able to do, then definitely we will do. So many times what happens is, if you have a true peripheral lesion which is close to the pleura, we'll first take the opinion of a radiologist, whether you are able to access it or not. If he says yes, we will send it, because that is definitely more cost effective, and if they're able to get a good biopsy, it definitely will have a better diagnostic yield to some extent. But if they say no, then we will still go in. But then many nodules come where both these 2 criteria are not there, where you don't have a typical CT bronchus sign and it is not in the peripheral 1/3 of the lung parenchyma also. There, I think we will discuss with the patient both the options, and then we will plan a procedure.
Okay, I think excellently put. I think, because if a nodule, I think, is very, very close and very peripheral, I think in that kind of a setting, an image-guided biopsy approach, I think obviously scores and is likely to be associated with the highest yield. The confusion happens in the middle third nodules where you have to take a case-by-case decision and have a look of the radiology and go ahead. So just as an introduction to my next question to Dr. Umang, Nagarjuna,
Yes.
did you use a guide sheath or fluoroscopy in this patient, or it was just a radial EBUS without a guide?
In this patient, if I remember, we have used a guide sheet. It was a very small thing. We had used a guide sheet, but we didn't use a CM because it was too small to be noted on a CM. But many times, actually, for small nodules, we now started using CM because we will have a rough idea as to where our forceps should go. So in this case, we used the guide sheet, but in that particular case, we somehow didn't happen to use a CM.
Yes.
Okay, so I think I'll just get my next question to Dr. Umang now. So Dr. Umang, so this was a case in which for a small nodule, a radial EBUS was performed and a navigation was used for guidance. So what do you think? Do you routinely use a guide sheath or a fluoroscopy while using these nodules? What do you think? Is this useful? And like in our setting where there can be resource limitations, so what do you think it really adds to our bronchoscopic diagnosis, or can be used on a case-to-case basis?
Yeah, thank you, Dr. Vishwesh, to make me a part of this panelist. Now, going with the case, I would say that if we go with the fluoroscopy, obviously that would improve the rate of detection, and obviously that would reduce the time for the histopathological diagnosis, because we right away go down to that subsegment or a segment of that apical lobes, which are very difficult to approach. Now, in this particular case, right middle lobe, where the lesion was pretty good, of size maybe around 20 millimeter or maybe whatever. So if we go with the guide sheet, that would help us to first of all tamponade the effect of the bleeding. If we go with the cryobiopsy, because I would always go with the cryoprobe, and that to 1.1 or maybe 1.7. Now, looking at all my cases, what we have done in last maybe 3 years, the guide sheet has not helped us a lot, because there would be a king to the guide sheet and the tissue retrieval would be very difficult. The tissue would be big in size, and we are doing a blind procedure. We don't know, even after the activation time, how big would be the piece. So better we go down with the radial EBUS and the pediatric scope, and that would help us a lot to get the right, maybe a good piece of tissue and for the histopathological diagnosis. And obviously the fluoroscopy would add to the refinement of the procedure that would improve the rate of detection at the end of the day. And again, if we have two things, at the same time, a lymph node and the pulmonary nodule, why don't we go for the lymph node only? Because you have rightly said that, that will be less the time, and the rapid on-site examination would give us a diagnosis at that procedure itself. So we don't need to go with the nodule. And whatever, the peripheral pulmonary lesion, less than 30 millimeter, maybe less than 3 centimeter, the radial EBUS with the guide sheet and with the pediatric scope would help us very well. And fluoroscopy, I would say that, yes, we can see that very well where the probe is going on, because if we use a guide sheet, the probe would be very less, the size would be less. And so the size of the piece would be definitely not adequate enough to get the histopathological diagnosis. So better we go with the cryoprobe 1.7 and not 1.1, or maybe even the normal, forceps biopsy, which would be enough to get an adequate tissue for the histopathological diagnosis.
Okay, useful points there, Dr. Umang. So I think you use the cryoprobe a fair bit, and I think not a lot of preference to use the guide sheet at your side. So I think one issue with the guide sheet would be that if your assessment of forceps opening or closing may be a little difficult once you're using a guide sheet and fluoroscopy is not there. So you sometimes with a small forceps you might not get that feel whether your forceps actually opened or not, which is not the case if you are not using a guide sheet. Fluoroscopy obviously depends on the kind of equipment. It's kind of an expensive setting if you go for a good equipment. And I think those issues also come in our setting. But I think there's a fair bit of literature that the radial EBUS sampling can be performed without the use of a guide sheath. And if you are reasonably certain, fluoroscopy. Fluoroscopy also gives you an advantage of detecting an on-table pneumothorax.
Yes.
And that can be one more addition.
We just, perform.
Can I just add one thing?
Maybe, yeah, sorry.
Yeah, so Umang and then Nagarjuna, yeah.
Yeah, sure. So we just performed one case live. We did a workshop and we did 6 pieces. We took 4 from the lower lobe, right lower lobe, and 2 from the right upper lobe. To our surprise, all the lower lobe pieces were not showing any histopathological diagnosis. And the 2 pieces from the upper lobe, they went for histopathological diagnosis and showing hypersensitivity pneumonitis. So the point what I want to make it is, we can't keep on taking the pieces, and at the end of the day, we don't get a diagnosis. It's better, to go with the cryoprobe, get a good adequate tissue. And more important, the size of tissue, the adequacy, the architecture, distortion should not be there. And more important, we are more confident enough that yes, we are going to get something at the end of the day, right? So I would say that forceps biopsy is still there, but obviously if you go with the cryoprobe, it would have an edge to get your diagnosis when there is peripheral pulmonary lesion, and that too, in the subsegment or the segment, and very much to the peripheral next to the pleura.
Right. So Nagarjuna had a comment there.
Yeah. Regarding the use of guide sheath, I think 2 things also we should consider. So guide sheath basically serves 2 purposes. It will fix the accessories to that module where we are biopsying. It will also help control the spillover of bleeding. Yeah. So if we are doing it for a very small nodule, like for example, which is below 2 centimeters or below 1 centimeter, then definitely using a guide sheath will ensure that we are probably getting the sampling from that particular location. The chance of mis-sampling, either overshooting or undershooting, actually comes down. 2, if you're doing a biopsy in a person who's at a higher risk of bleeding, for whatever, for example, he has PAH or he's on antiplatelets, then definitely having a guide sheath will also decreases spillover bleeding. But if these 2 are not there, if it's a reasonably larger lesion with no risk of bleeding, then as you had said, many times we tend to get bigger biopsies without using the guide sheath.
Excellent points there. I think the stability of the lesion sampling and the reduced risk of bleeding are possible advantages. So I think Dr. Umang brought out a hot topic, which is quite cold in interventional pulmonology, is the use of cryotherapy. We have Dr. Kedar also. He's published on the use of cryotherapy also for PPLs. One of the earlier articles, it was probably one of the earlier articles in the use of cryotherapy for peripheral pulmonary lesions. I'll just go there. Okay. So I think I'll just put a question to Dr. Kedar here is, what do you think is the role of cryotherapy for the or use of a cryoprobe for sampling the peripheral pulmonary lesions? That's number 1. And do you think it really adds on to the diagnostic yield? And thirdly, there is a lot of data on the standardization of cryobiopsy for lung, for the diffuse parenchymal lung disease, but not so much data for cryoprobe guided sampling for PPLs. So what is the strategy you would recommend, and what do you think is the role in sampling the PPLs?
Karan, thank you for the kind introduction earlier, and Vishwesh for including me in the panel. You asked me a couple of questions on cryo, and I'll probably brief you on it. There are few distinct differences that we've always preferred a cryobiopsy for in favor of a, vis-a-vis a forceps biopsy. The fact that you get a round spherical biopsy from a cryo probe is what something, and a larger piece is actually what adds to our diagnostic yield. And that's really what we are looking for in a cryobiopsy. In the era of, genetics and immunotherapy, the pathologists want more and more. They are always in the dil mange more mode, and therefore it is very important that we give them larger chunks so that the final goal of the patient getting chemotherapy or a surgical resection with a curative intent is what we are trying to help them out with. So in that sense, cryobiopsy definitely scores over the forceps biopsy. So that part of the debate is completely settled, that cryobiopsy gives larger samples, cryobiopsy adds to your molecular diagnostic yield, and so on and so forth. So that is something that is known. What happens when we are doing peripheral pulmonary lesions is the type of lesion that you see on the on your radial probe that actually makes the difference. So there was a paper, in fact, in our paper, which you were just referring to, and also the paper by Zhe and T, who spoke earlier in this particular conference, you can actually see that when you're talking about a central lesion, your yields are always good. But when you're talking about adjacent or eccentric lesions, since cryobiopsy takes a full circular kind of a biopsy or a spherical biopsy, it apparently adds a little more. And in fact, in their paper, they've actually found that spherical and the spherical biopsy obtained in eccentric and adjacent lesions have a much better yield compared to just concentric lesions. So concentric lesions, there's no debate. It is going to give you a yield wherever you biopsy. But when you go in with a forceps, you don't know which edge you're biopsying, and therefore a cryo is likely to give you a much better yield. So I think cryo definitely adds to your yield. But yes, it again comes with a lot of caveats like bleeding. And I think you actually rightly brought out the point. What has happened in the literature is, while we've been peripherally, the peripheral nodules are being sampled for a very, very long time, we're now looking at cryobiopsy, and most data on peripheral pulmonary lesion cryobiopsy is now getting extrapolated from the DPLD data. So in DPLD, one of the papers which you have yourself published in Lung India, which is standardization of the procedure with a rigid, adding a balloon in it, is something that I think in peripheral centers needs to start getting replicated even to solitary pulmonary nodules. I think at the end of the day, we always have to look at a risk-benefit ratio. But having said that, even if there is a, most data says the complication rate is between 2 to 3%. And that's quite a lot, actually. 2 to 3% is not very little. And 2 to 3% was actually in a meta-analysis with forceps biopsy. And now we're talking about cryo. And in the, Dr. T's paper, they've actually quoted a rate of about mild bleeding, about 39% and moderate 7.9. 7.9% moderate bleeding with a cryobiopsy is quite a lot for us. And I think it is important that we have all backups in place and a balloon in place. I think there is a greater need for standardizing the procedure for peripheral pulmonary nodules, just the way you've done for cryobiopsy. But I think we're getting there sooner or later. And I think maybe somebody from PGI or you may have to write up a paper on standardizing that procedure as well. So that's how I see it. But yes, please do. It is very important to insist that, take all precautions and have all standby, like a balloon at least in place before doing and attempting such a procedure. That's something that should be the takeaway.
Excellent points brought in, Dr. Kedar. I think,
and one other point which I forgot, and just sorry to add here. I think traditionally we've been having the 1.9 and 2.4 mm probes. The 2.4 mm probes have never really been discussed in the SPN data, the solitary pulmonary nodule data. But with the increasing availability of 1.1 and 1.7 ERB2 cryo probes now, I think even the Zhe paper or my paper, we've only used 1.9. We still have no official large study on the 1.1/1.7 mm probes yet. So I think that's another area which we need to look at, not just for DPLD, but I think there's already a lot of stuff happening in DPLD, but for the SPN data, especially from, resource poor settings or, moderate settings is what we need to get out from, centers. And I think that's really where we should be looking at, because all data is about 1.9. We really have no much data in the sense of large studies. It may be case reports at best, and I think we need to start looking at 1.1 and 1.7 mm probes.
Yeah, excellent points there, Dr. Kedar. I think one of the key messages from the available guidelines for doing cryobiopsy in DPLDs per se is use of an occlusion balloon and the use of a protected airway. The protected airway can be ideally a rigid bronchoscope or an endotracheal tube. So, I mean, just a group's opinion, for those of us who perform a cryobiopsy, how many of us use a protected airway? I mean, an endotracheal tube or a rigid routinely?
Yeah.
So, okay. So I think most of us do that. So that's heartening. I think most of us would be using an occlusion balloon, which is kind of important. So
can I make a point?
Yeah. Yes, Dr.
Yeah. Like, if we go with the rigid bronchoscope and the Fogarty balloon, as simple as that, we have never encountered any massive bleeding. If the assistant is pretty good enough and is experienced enough to inflate the balloon at the right time, I'm sure, no bleeding would be there. So this is like, kind of that cryobiopsy would have more bleeding, more pneumothorax, fair enough. The pneumothorax might be there. Then you need to put the tube in later on. But regarding the bleeding, there should be no doubt that if you are good at procedure, you will never encounter massive bleeding. And if everything goes well, obviously the patient would have an adequate tissue that rightly said by Dr. Kedar for ISC staining and the targeted cell therapy. Nowadays, a lot of medical oncologists want that particular thing in their tissue.
Right, excellent point. So I think we recently did a meta-analysis of comparing the diagnostic yield of cryobiopsy versus forceps biopsy for peripheral pulmonary lesions. What we found interestingly was still, we found the yield of both the modalities to be same. But I think, as you said, the data in the adjacent and eccentric lesions is interesting and needs to come out with the use of smaller probes to see how it, fares ahead.
Kedar, I will add one point.
Yeah, Hari, yes.
We were discussing regarding peripheral lesions and 1.1 probes. No? Unlike these 1.9 probes, which are very soft, they take the shape of the bronchus and go till the periphery. But 1.1 is a very stiff probe. So you don't know, because as you go to the periphery, there is a chance that it might rupture and then go on to the pleural surface also. That's what I am experiencing, because it doesn't go, it goes in a, it goes perpendicularly, it hits the wall and you don't know whether you're piercing it or not. Maybe you also might have the same experience. Any experience from the group?
I don't have a 1.1, 1.7 mm probes yet, so I don't have personal experience with that. I'm currently using a 1.9 probe itself. And what I biopsies, I don't go to the complete periphery because I still do not have the 4.2, 2.0 mm channel scope, which I'm likely to get sometime, before the end of this year. So I'll be able to share my experience better. But at this point in time, I choose lesions which are not completely peripheral. If they're completely peripheral, then that's something that I try and send it to my radiology colleagues. But even in those lesions, I try to look for a bronchus sign.
Maybe when using 1.1.
Those are the two areas which I really look for before I decide whether I'm going to choose this patient for biopsying or not. Sorry, go ahead.
Maybe I would like to add to Dr. Hari's
the guide sheet and then go through the guide sheet. That would be easy. But again, sample size may hinder the diagnosis.
Okay, I think interesting points here, observations of Dr. Hari, that maybe the pneumothorax and going distal may be high. Dr. Vishwesh has a point, I think. Dr. Vishwesh.
Yeah, actually, we have been using 1.1 probe for quite some time now. So what we do is, like, initially what we faced also, like, the sheet actually doesn't help, because when you freeze for a more time, actually you end up almost facing a lot of resistance and you just leave that piece there only without taking the piece. So what we have started using now is we have removed the sheath. We are just using, just like as we use a 1.9 cryo probe. And in our observation, we are more confident in doing cryobiopsies with the 1.1 because we don't tear, we don't create a pneumothorax to a great extent, or we don't have a risk of bleeding. Also, it's very minimal because of the freezing area it has. So the one addition in Indian, what we can do is we can remove the outer sheet and we can use this 1.1 cryo probe. And as Dr. Hari sir said, like the stiffness of the probe. In fact, we also faced it, and in most, in few conditions, we even use this 1.1 probe to break open a web because it is as stiff as you use any other conduit. So it's a very stiff probe, and we have to be very careful, especially when we maneuver through smaller bronchus.
Yeah.
Right. Very, very useful observations there. I think in this case, maybe the use of fluoroscopy may help, that it can actually tell you where you are. And I think if you use an occlusion balloon and your balloon is working well, bleeding mostly should not be an issue. And I think pneumothorax is something which we have to look out anyways. Right. So I think we had a very...
Can I add one more thing?
Yes, Nagarjuna, please. Yes.
So actually, we're discussing two things. One, when to do a cryo, and two, which probe to choose. Correct? So to do a cryo, I think everyone accepts that if you have an eccentric image, definitely cryo will add to it. So that is one thing where there is no debate. Second thing is what we also started using is in Rhodes negative cases. Even for radiolibers, luckily we have a pathologist who helps us. And even if you have a concentric image and the pathologist is not able to give any clue. So that is another group of people. Now slowly we started preferring cryo over a forceps, but that again I don't think is evidence based. But that is one group of people probably where the chance of we getting a diagnosis can be increased.
Excellent comments. I think, that the cryotherapy is a very hot topic, nowadays, and you've got a lot of data in the, there was a big paper in ERJ regarding the use of cryoprobes for intranodal biopsies. So I think those are the things which are, coming in. I think so we'll have more on this in the due course of time. Okay, so I think we'll move on. I think I'll now like to bring in Dr. Yugandhar. Now that we've obtained these samples, so what is the set of investigations, Dr. Yugandhar, you would prefer to send on these samples? I mean, what all kind of samples would you like to be obtained while you are doing a radial EBUS guided sampling? And, how routinely you would investigate for TB in our settings in peripheral lesions?
Karan, I think Yugandhar is not.
I think we have lost Dr. Yugandhar.
Right. So anyone else, Dr. Vishwesh, you can probably take the question for him. Maybe, I mean, what all set of investigations you would perform, and how, and would you routinely investigate for tuberculosis, regardless of the appearance of the nodule?
Yes, in Indian context, yes, definitely we will send this sample for at least gene expert and for ZN staining, because the cryo we generally do not send it for culture, because that has been the directives from our microbiology department, like the cryo sample doesn't yield the culture reports. So we routinely send the cryo sample for histopathological diagnosis along with the ZN stain, and we even send it for a molecular analysis in the form of a gene expert. And apart from that, what we make sure is, because we always require a culture report, we make sure that we take the ball prior to the procedure. And this ball gives us most of the infective culture diagnosis, which we really require, which we lack when we do just a cryobiopsy. So a perfect ball at a location where we are suspecting a nodule for an infection with all the, including modified AFB stain for nocodia and pyogenic gram stain and culture and a fungal smear and culture, and a ball for an AFB and a liquid culture. Along with that, we take the tissue sample and send it for HP with ZN stain as well as for a gene expert analysis.
Excellent. So I think this needs to be highlighted, that, in our setting, we often see, cases which are suspected as malignancy turning out to be infectious. And so I think this needs to be kept in mind that, get a histopathological diagnosis, but then you are looking that a culture sample was possibly not sent or missed. So I think a complete set of investigations is kind of ideal and should be performed. So Nagarjuna, bringing you in again. Any tips or tricks you would like to, put ahead regarding when you use an approach towards PPL, especially a bronchoscopic approach? And do you think settings which don't have, even radial EBUS, say an operator does not have a radial EBUS, but he's got, say, fluoroscopy. So what is the role of a blind fluoro-guided transbronchial biopsy in peripheral pulmonary lesions?
I'll take the second question first, because I think that's probably easier. I think there has been enough data pre-radial EBUS on fluoro-guided biopsies, and the yield has been dismal, I think below 30%, if I'm not wrong.
20%.
Below 30% is what I said. So it's around 10 to 30%.
Yeah.
So unless until the lesion is huge and you have a two-dimensional fluoro where you can rotate it, I wouldn't recommend a pure fluoro-guided biopsy, because many times it's a unidimensional fluoro in most of the centers, and it doesn't help much. That is the first one. Second, tips for image for bronchoscopic diagnosis for PPNS. Two things. One is to pre-plan the procedure, at least to shorten our time. CT, planning a CT will actually help a lot. At least you know where you have to go. At least you should try to localize the segment, at least the segment where you want to search, or one or two segments, so that you will decrease the time searching for the nodule with the radial EBUS. Two, having the armamentarium ready, because even though you do a radial EBUS, many times pre-priori you don't know whether you will get a concentric image or an eccentric image. CT may not always help you. It's always better to have everything ready. So that is another thing which will actually help. And I think this is the two things. And as you, the more you do, there is definitely a learning curve for radial EBUS, unlike linear EBUS. So in most of the centers also, the first 20-30 cases, you tend to get lesser yield, but then as you keep moving ahead, your yield of the EBUS definitely goes up. So definitely there is a radial EBUS learning curve, and we should also keep that in mind.
Excellent comments here, yeah.
Karan, can I add one more point to what he's already told? So your question was a very interesting one. You wanted us to use fluoro and do a blind biopsy. I think Nagarjuna has touched the nerve by saying that pre-planning and looking at your CT is extremely important. We don't always have that luxury because sometimes patients come with CT scans from outside, and repeating a CT scan means additional costs and also additional radiation. But I think the other important point is also what bronchoscope you have. And I think that's something that plays a very, very important role. Traditionally, our scopes were around 5.5 plus, and now they're starting to get thinner, even thinner. And I don't know what's going to be the thinnest scope. What we have currently and what most people speak about is the P190, which is a 4.2 2.0 channel. I mean, you have used a prototype, in PGI, and that is the MP190 with a 3 millimeter external diameter and a 1.7 mm channel. But many people who have used it informally have told me it's a little flimsy. What I think is required is a good, starting out scope, which is about 3 to 3.5 meter, millimeter external diameter with a 1.7 mm channel. That's really what we really need. The 4.2 and a 2.0 is currently doing a good job, but I have no experience with the 3.0, 1.7, MP190 scope. So I think a bronchoscope choice is something, I think, your question's simple answer is exploit everything that you can to the best of your ability. So use a thinner scope. If you have a radial probe, use it. If you don't have it, if you have fluoro, use it. But before that, I think before entering, please read your CT scan to the best of your abilities. I've always found, in my own mind, I've always had the debate how good navigation is. Nagarjuna has already shown the data in many conferences, and I know it's good. But sometimes I feel a good CT reading itself can help you get to that segment or the subsegment level. If you read the data from the Japanese side, vis-a-vis the American side, if you go to the American and the European side, it's more navigation and navigation and navigation. If you go more towards the Japanese and the Malaysian side, you will find read your CTs better, plan it, look at the segments, look at the subsegments. I think, we have to find a balance between the two. I'm not saying every, lesion will require navigation. On the other hand, every lesion will not necessarily be, just enough reading a CT. But I think a best of both worlds is something that we should exploit. So the best answer to your question will be use whatever you can, throw it at that lesion and try to get the best possible sample you can. If you have a cryo, that's great. If you don't have, use a forceps, use a fluoro. That's really about it. That's how I would go for what you proposed.
Right. So I think it's important to remember, the available literature to us still indicates that, overall the yield of bronchoscopic modalities for peripheral pulmonary lesions has still not reached where we would like it to be. I mean, even with all of our experience, we many times end up with patients who are non-diagnostic despite a bronchoscopic approach. And so I think we are getting a lot of advancement into peripheral pulmonary sampling. But I think it will be still some time before we reach to a level in which, a game changer like EBUS TBNA happened for the mediastinal lymphadenopathy. And second thing, which is very important, I think it will play a very major role in our setting, is all pulmonologists to be good readers of CT. I mean, if you know and read your CT well, I mean, you will really know where and which segment, I think Dr. Kurimoto from Japan, he has got a dedicated Kurimoto's method in which, just by a careful review of the CT images, by flipping them, you can actually get a decent idea of which segment your lesion is in. So I think I'll just, we're coming to the concluding end of our, session. I think I have a question for Dr. Vishweshwaran here. So what do you think, Dr. Vishwesh, that do you think CT guided sampling or percutaneous image guided sampling is still the major modality for a diagnostic approach to PPLs in most of our setting. And I think we need to somehow have algorithms in which we choose a careful balance of the two modalities. And when in doubt, probably refer the patient for an image-guided approach.
Yeah, the simple answer would be still yes. CT-guided or image-guided biopsy still holds gives us the yield in a resource-limited setting like India in most of the places. Because we are not going, whatever we are speaking in this conferences about robotic bronchoscopy, radial EBUS, and all these things, these are still limited to best of the centers, which are very few in a country like India. So in most of the other peripheral centers, you still have to rely upon either an ultrasound guided biopsy or a CT guided biopsy. And the yield, when we compare the yield, even with the best of the modalities we have in combining a navigation, combining a radial EBUS, we still have not reached the yield as we would reach for a image guided biopsy, because in image guided it's anytime a real time visualization, which unfortunately we lack when we are using these navigational platforms. But however, this might be overcome by the advances happening in the Western world, like the use of a robotic bronchoscopy, which we had it in our previous lectures. And the third point is the experience of the person who really does the procedure matter a lot. And as we have seen from the panel discussion today, where most of our panelists are people who are day in and day out doing these radial EBUS and image navigation systems, but still they also confer the fact that they have never had 100% yield, and the learning course has still been a lengthy process. So till the time we don't have the learning platforms, then probably we will never be able to match the sensitivity data which we obtain from the Western population. So given all these constraints in our scenario, I still feel that image guided or a CT guided or an ultrasound guided would be the primary modality of a choice, except for a subset of population where you have a lesion in the central 2/3 of your lung. You don't have a means of, or you have a very emphysematous bulla obscuring your CT guided biopsy, or you don't, or a rib obscuring the lesion, then probably for rest of the lesions, we would still prefer an image guided biopsy.
Yeah, right. I think important points here. I think an operator experience really matters. And I think a careful review, and if you see a bronchus adjacent to the lesion or a bronchus sign, I think that would be very encouraging. If your nodule is larger, I mean, if it's 2 centimeters or more, or even a centimeter or more, with a bronchus sign, you may be encouraged to, approach it with your experience. But I think a case-by-case decision is something which is very important, and you have to take, decisions accordingly. So I think we've had a very, very interesting discussion. A lot of points have been brought out. If there are any concluding comments from any of our panelists before we wind up, any comments from?
Yeah, I take this opportunity to thank all the panelists, and especially you, Dr. Karan Madan, for moderating this session. And it was really a nice one and a nice gesture from all of you. Thank you.
I think, thank you, Dr. Vishweshwaran. I think it's very encouraging to have a dedicated session on peripheral pulmonary lesions, because the innovative modalities are moving in. We would have them soon. And it has been interesting learning to see how we could integrate into our armamentarium and how we can choose it for the best of our patients. I would like to also thank all my colleagues and panelists for joining in, and thank you and good night.
Thank you, Karan. Thank you.
It ends here, sir. That's it. The recording is done.
Thank you. Thank you very much. Yeah.
Okay. Yeah. Thank you, sir. Thanks a lot.
Thank you, Karan. Thank you, everyone. Thank you so much.
Thanks, everyone.
Thank you, expert speakers and the panelists, for being a part of this wonderful academic program. I hope this academic program has really helped in providing newer insights into the management of peripheral pulmonary lesion. Very soon, or at least in the near future, we will be having access to all these advanced modalities. And I think it is in the best interest of the advancements in the interventional pulmonology that we keep ourselves updated about the latest technologies. And thank you once again for joining us in this web meet, and hope to meet you soon. Thank you from the group of Yashoda Group of Hospitals from the Department of Pulmonary Medicine. Thank you.